Welcome to Mega Life Sciences, established in 1980 and a public company since 2013. With a global presence in over 33 developing countries, and GMP approvals in over 50, Mega is a leader in the health industry. Mega Life Sciences has proudly served the people of Rwanda for over 9 years, supporting health and wellness in the region. Our manufacturing plants span across the globe, ensuring the highest quality products for all. At Mega, we believe in helping people stay healthy as long as they live. We are passionate about women's health and focus on developing brands with the modern woman in mind. During pregnancy, nutrition is key, but diet alone may not be enough. That's where Mega Prenatal comes in. Small, easy-to-swallow capsules packed with essential micronutrients for a healthy pregnancy. Ferritone offers a breakthrough liquid in a capsule formulation, eliminating metallic taste and GI irritation for easy, assured iron absorption. Calcivita's small, vanilla-flavored capsules ensure optimal calcium absorption without digestive discomfort. For fast relief from pain, Gofen's unique clear cap technology delivers results in just 15 minutes with minimal GI irritation. Mega's portfolio includes a NAT 400, the purest form of natural vitamin E, Zeman for enhanced testosterone support, and a NAT cream for flawless skin with reduced stretch marks. With a wide range of innovative products, Mega Life Sciences is committed to your health and wellness, wherever you are.
Mega, we care.
Welcome to Mega Life Sciences, established in 1980 and a public company since 2013. With a global presence in over 33 developing countries, and GMP approvals in over 50, Mega is a leader in the health industry. Mega Life Sciences has proudly served the people of Rwanda for over 9 years, supporting health and wellness in the region. Our manufacturing plants span across the globe, ensuring the highest quality products for all. At Mega, we believe in helping people stay healthy as long as they live. We are passionate about women's health and focus on developing brands with the modern woman in mind. During pregnancy, nutrition is key, but diet alone may not be enough. That's where Mega Prenatal comes in. Small, easy-to-swallow capsules packed with essential micronutrients for a healthy pregnancy. Ferritone offers a breakthrough liquid in a capsule formulation, eliminating metallic taste and GI irritation for easy, assured iron absorption. Calcivitas small, vanilla-flavored capsules ensure optimal calcium absorption without digestive discomfort. For fast relief from pain, Gofen's unique clear cap technology delivers results in just 15 minutes with minimal GI irritation. Mega's portfolio includes a NAT 400, the purest form of natural vitamin E, Zeman for enhanced testosterone support, and a NAT cream for flawless skin with reduced stretch marks. With a wide range of innovative products, Mega Life Sciences is committed to your health and wellness, wherever you are.
Mega, we care.
Welcome to Mega Life Sciences, established in 1980 and a public company since 2013. With a global presence in over 33 developing countries, and GMP approvals in over 50, Mega is a leader in the health industry. Mega Life Sciences has proudly served the people of Rwanda for over 9 years, supporting health and wellness in the region. Our manufacturing plants span across the globe, ensuring the highest quality products for all. At Mega, we believe in helping people stay healthy as long as they live. We are passionate about women's health and focus on developing brands with the modern woman in mind. During pregnancy, nutrition is key, but diet alone may not be enough. That's where Mega Prenatal comes in. Small, easy-to-swallow capsules packed with essential micronutrients for a healthy pregnancy. Ferritone offers a breakthrough liquid in a capsule formulation, eliminating metallic taste and GI irritation for easy, assured iron absorption. Calcivitas small, vanilla-flavored capsules ensure optimal calcium absorption without digestive discomfort. For fast relief from pain, Gofen's unique clear cap technology delivers results in just 15 minutes with minimal GI irritation. Mega's portfolio includes a NAT 400, the purest form of natural vitamin E, Zeman for enhanced testosterone support, and a NAT cream for flawless skin with reduced stretch marks. With a wide range of innovative products, Mega Life Sciences is committed to your health and wellness, wherever you are.
Mega, we care.
Hello, everyone. Good morning. Good morning. You want to give me a wave? Say good morning. Thank you. Sorry for the delay, but if you weren't here last night, welcome to the 10th RSOG Annual Scientific Conference. So today is going to be all about diving into the scientific part of this conference. Yesterday we had a beautiful opening ceremony where we shared our passion, we shared knowledge, but also we had a little warm-up to today's session. So we're going to dive into the theme of empowering the health workforce and driving progress in women's health. Now, to dive more into this, I'd like to welcome the chair of the organizing committee of RSOG, Dr. Habimana Emmanuel. Give him a round of applause. Thank you.
Dear Head of Department for Health Workforce Development at Ministry of Health, Dr. Menelas Nyeshimana, who is representing the Ministry of Health, dear FIGO President, Prof. and Kihala, dear RSOG President, Dr. Victor Mivumbi, respected invitees from different professional societies, Ministry of Health, universities, UR, and UGH, and so forth. Dear Director Generals, respected your rank according to the hospital's levels, representative from development partners, civil societies, organization, distinguished participant, dear colleague, obstetrician, gynecologist, invitees or protocols observed, ladies and gentlemen, good morning. It is indeed a great pleasure for me to extend you all a very warm welcome in this conference on behalf of the organizing committee of the 10th RSOG Annual Scientific Conference. Dear participants, you are here in this room to attend the conference that has got the theme, empowering health workforce to drive progress in women's health. And you can ask, why did we choose this theme? So our country has done a lot to ensure a high quality access to healthcare services, not only in women's health, but in all domains of health services, thanks to the good leadership led by His Excellency, the President of the Republic of Rwanda, Paul Kagame. But it's still a persistent struggle for the government and the policymaker as we are facing a global deficiency of inequality trend, competent and motivated healthcare professionals, not only in Rwanda, but worldwide. And according to the World Health Organization, in 2016, there was projected deficit of 18 million healthcare workers need to realize universal health coverage by the year 2030. Then 6 years. In Africa, the ratio of obstetrician and gynecologists per population is generally lower compared to the other regions, particularly in rural and remote areas where health care infrastructure and workforce shortage are more pronounced. The government of Rwanda highlights the importance of addressing women's issues and is committed to improve women's health in fighting against persistent challenges such as maternal mortality, reproductive health disparity, and limited access to quality health services. Health workforce empowerment is essential to driving progress in women's health as they are equipped to provide comprehensive care, promote preventive measures, and address the complex needs of women across their lifespan. By investing in training, capacity building, and professional development of healthcare workers, countries can strengthen their healthcare system and improve outcome for women and their population in general. And in this struggle, RSOG, this is the Rwanda Society of Obstetricians and Gynecologists, plays a crucial role in empowering the health workforce through its advocacy efforts, educational initiatives, and a collaborative project striving to enhance the skills, knowledge, and resources of healthcare professionals working in obstetrics and gynecology by fostering supporting environment for various learning and innovation. RSOG empowers its members to deliver high quality and evidence-based care to women across Rwanda. RSOG is also contributing to various opportunities to training in telemedicine and strengthening interprofessional collaboration. And today we are speaking with the Minister of Health 4x4 reform, which is a visionary strategy aimed at quadrupling the number of health workers in the country within the next 4 years to meet the WHO recommendation of at least 4 healthcare providers, professional per 1,000 population density. RSOG, in partnership with the Ministry of Health, the University of Rwanda, and other partners, have started the level 2 teaching hospitals based residents whereby 40 residents are already being trained. Dear participants, the 10th RSOG's annual scientific conference aims to explore the innovative strategies and best practice to empowering the workforce to drive progress in women's health through engaging presentation, interactive workshops, and knowledge sharing session. This conference will provide a platform to exchange ideas, build networks, and develop sustainable plan to catalyze positive change for advancing women's health in Rwanda. Throughout this conference, from yesterday, where we had 2 sessions for pre-conference workshops, where we had minimal invasive surgery and the hands-on hysteroscopy, and we had 12 participants in emergency obstetrics care. 37 participants were there, and today and tomorrow, we will have 14 presentations who will be orally, and then we will have 5 plenary talk and 3 panel discussion with great and known speakers here with us. And we will also have 2 stage lecture given by experts in women's health. I would like to request you all to stay engaged throughout the conference and contribute with your valuable knowledge and expertise. Before I conclude, I would like to take this opportunity to express our sincere thanks and gratitude to our chief guest who was here yesterday, the Director General of Rwanda Biomedical Center, Prof. Mambo Muvunyi, Claude, who has given his valuable time yesterday in opening ceremonies, and we acknowledge the presence of the President of FIGO, Prof. Ann Kihara, who has remained present among us since a couple of days back instead of his busy schedule. I can tell you that your kind presence, dear President, has increased the importance of this conference. I'm thankful to all guests here present and RSOG, various partners, sisters, professional societies, and the regulatory bodies, including RMDC, for their kind presence. I'm also thankful to the RSOGC. This is Society of Obstetricians and Gynecologists from Canada, who has taken the pain to travel from Canada to attend and contribute to this conference with their invaluable expertise. Last but not least, thanks are also due to RSOG Executive Committee members for providing the good working environment, their office staff, they are young and they are very active, very rapid. They help us when we were organizing this conference. And people from organizing committee, you did a very great job. And we acknowledge your effort to make this conference happen. I would like to thank each of you again for attending the conference. And also remember, tomorrow, that will be Friday, and you have to start your week enjoying this green town, Kigali, and enjoying the beauty of the country of 1,000 hills. Thank you very much.
Thank you for that. That was amazing. So next up, we have a great woman, the FIGO president, Anne Kihara. Thank you. Give her a round of applause.
Sorry, I have to turn it a little bit. Good morning, everybody. Good morning. You've had breakfast, you're in a nice place, or are you in a bad home? I really want to indulge your attention, and I want to start a little bit differently. But this is after I do the protocol. Dr. Victor Mvumbi, RSOG President, the executive and advisory team, and administration staff. Dr. Menelas, the second name is difficult. Health Workforce Department, MOH. I hope I will do justice to 4x4. Prof. Bebe Bekele, Deputy Vice Chancellor, University of Global Health Equity. Professor Abram Mijike, Principal of College of Medicine and Health Sciences, University of Rwanda. The Director Generals of the hospitals represented here, the academicians, I've seen very good friends, private sector that is also in the house, colleagues, my postgrads, I know you're here, and civil society, and SOGC. Good morning, everybody. I want you to all close your eyes. Just close your eyes for a minute. And just imagine, you're not closing, some of you are having open eyes. I want us to imagine a world without women. There's no woman in the world, there's no baby being delivered. What will happen to that world? Open your eyes. Then I want to give you a reality I can express because I too am a healthcare worker. I have worked in both public and private. I have seen it all. I have worked in an institution where you have an average of 80 patients to be seen every morning by a complement of staff of 4 and probably 6 nurses. 5 of them are in second stage. I only have 2 beds to deliver them. What kind of quality really will you get as a result of that? When you're talking about rights-based, patient-centered, respectful care, will it really happen? Unlikely. But as a healthcare worker, I'm trying my best with what I have. And this is really what informs where Rwanda wants to go with empowering the health workforce to drive progress in women's health. Next slide. So I started by giving a quote. Next slide, please. I'll rush you, so, okay, I'll do it myself. Right, this is the background. I won't belabor to it, but I want you to also look at your performance on Countdown 2030, the transformation of Rwanda. Some of you are hearing 4x4, but I went back to the archives of the knowledge. Your HRH means Human Resource for Health. The transformation really started in 2012 in Rwanda. So I will progress you from there. Empowering the health workforce, envisioning. I'm a dreamer. I'm a real dreamer, and that's why I made you dream. So we will dream even beyond 4x4. And then finally, I want to tell you I have no conflict of interest. I'm just trying to be Rwandese in totality. This is what I'm putting up as the first most important and only slide if you don't remember anything. Sexual and reproductive health and rights needs to be provided with the highest attainable standard, inclusive of emergency health. Human rights-based approach promotes, protects, respects, and fulfills. But you must be cognizant of two things: culture and gender. But no one should be left behind. The last and the least looked at is our accountability in the processes and outcomes associated with the reproductive system and functions in a woman's life course approach. Background. Sustainable Development Goals, we are less than 6 years to go, 2030. But this is the global public health. Globalization, epidemiological changes for health and disease, geopolitics, wars and conflict, fragile states, socioeconomic recession, emerging diseases, and those are going to continue. Emergency preparedness and disaster preparedness, climate change, food insecurity, and dwindling natural resources. When I say that, how many of us work in health facilities where there's no running tap water? You're lucky. I have worked in places where you have to first go to the river, pick water, come back, boil it, and then try to use it for your patients. You can only collect so much. That's my community experience. But we must remember the context of primary health coverage and the universality of health. And we're going to look at models of healthcare delivery and its service points. Employment of technology. I really like the fact in Rwanda you're really pushing that agenda. And address to gender disparities and health inequities. Health financing. This Abuja thing for 15%. How many countries have really achieved it? We will look at it. And I've given even how we can innovate on financing. We have the government, domestic sources, international and donor funding is dwindling, so we have to help ourselves. Grant and credit schemes, health insurance, performance-based financing, universal health coverage, public-private partnership. What's the challenge? How do we sustain? How do we redistribute this? And, of course, if you're empowering health workforce, we need money. You need to pay them. MOH. You need to pay us and not underpay us. Compared to the high-income countries, we've got a long way to go. And we need to provide patient-centered care. That includes what? Access, coverage, quality, safe. But above all, make it a positive experience. Do we think of that as we treat our patients? Strategic planning is needed, which you have nicely done. But what worries me is how much of data are you using to inform priorities, decision with context? Remember my patients I'm seeing? That context is very different from what I'll probably find in King Pfizer or what I will find in Canada. In Canada, it's a one-to-one. You monitor the patients at a nursing bay, and you can actually see CTGs on all the women. Very easy. So at the click of a button, you actually know, there's a problem in that room. And you can even convert that room into a theater. The patient doesn't move. But lo and behold, in Africa, it's different. So I have said this. There's need for critical investment in the human health workforce to deliver goal number 3, so that we have better productivity of citizenry and impacts on all other SDGs. My women are central. My women are central. So when you imagine the world without women, none of your SDGs will happen. So I've just picked it out and looked at the targets and highlighted what I've basically been saying. As we talk of SDG, you have to remember universal health coverage, the financing models, and sexual and reproductive health. But there's the big elephant, health financing and workforce. So we have a very relevant topic today. Then I moved on and I said, Global Strategy 2016-2030. EPMM, Ending Preventable Maternal Mortality, ENAP, Every Newborn Action Plan. And I want you to focus. Where we are, we must have 90% coverage of ANC. Does it happen? And reflect on your facilities. 90% skilled birth attendance, 80% with routine postnatal care. But that is at national level. When it comes to subnational and district level, we are saying, give us at least 80%. And what does that require us all to do? You can see a whole list of things. Look at your policies. Do you have an MNH policy? MNH, not reproductive health. MNH. I don't know. Quality of care, equity, data for action, investment, health workforce, response and resilience, commodities, accountability, and continued research and innovation. So as I thought, I said, okay, you keep on telling us about the health workforce, but we have challenges. Much as it's a capital investment. These are our challenges. What's the quality of training and skills, recruitment, qualifications, deployment? I want to be deployed there, in my urban city, not here, here. Where will my children go to school? Where will we sleep? Where is our house? That's how doctors think. That's why I put the pictures below. Then workload to workforce. The staff workplace experience. Yesterday I alluded to it. If you can't give me a cup of tea, you can't even give me lunch, but I'm on a 12-hour call, how much productivity will I really give back? I'll burn out. Or I'll brain drain and I'll say, let me go to the UK, to the US of A, and Australia, because that's where we're migrating to. And then in your activities as a health workforce, is it a siloed approach, or are you integrating services? Subspecialization. Yesterday we honored 4 people. You were young in Rwanda in subspecialization, but it's going to grow because you've put the mechanisms in place. PPP. Subira, my friend, how do I work at King Faisal and work in the public hospital and optimize output and outcomes? Ministry of Health, we need to really think about this. We are struggling in Kenya. A lot of doctors spend 1 hour in public, 20 hours in private, because that's where the money comes in. How do we balance this? I'm very real. Regulation. My regulator must be somewhere here. Accreditation of facilities and even healthcare workers. So here I like speaking to what we hate most, private insurance. Do you have a problem with them? They tend to have, in my country, a select group, some of it is fossilized, who are considered as the doctors on their panel. The rest of you, and unfortunately the younger generation, too bad. You'll never get there. So what can we do to stop that? And what can we do to stop them not appreciating the work you do? So they're always undercutting and undermining and saying, Daktari, here, please reduce the cost. It shouldn't be that way. I have given the service. Career progression, promotions, retention. When do I retire? You know, I like doctors. They work till they're 70, the eyes can't see, the hands are shaking, there's some degree of senility that has set in, but they're still working. Again, what's the quality of work? Or unfortunately, you made money in your younger day and you started drinking and having a good lifestyle change, so you have the shakes. Before you actually can do the laparotomy, you've got to deal with the shakes. These are our problems. And one that is really growing is industrial strikes. And I've put it there to show you, it's not just in Kenya, where we sleep outside the Ministry of Health because of poor remuneration, but even abroad. And what am I saying? When the doctor strikes and fails to go to work, the patient suffers. And unfortunately, it's that where the need is needed most, you get the worst outcomes. And what we don't seem to talk about is that it's going to be a lifelong tragedy for that woman and family. SDGs, I won't belabor to look at that so much, but you need to know there are targets, global targets, and ask yourself, where are we as Rwanda? And are we going to attain the SDGs 3? Globally, you can see at the bottom, unless we do something, maternal mortality has to be shaken by 9 times from where we are. Stillbirths, 3 times. Neonatal, 4 times. And the mortality of 1 to 5 years, 4 times. But time is not waiting for any one of us. It's ticking. We've got to do something differently. Then we have this slide. Still, this is all from the global strategy. What should we be giving as our services to women in the continuum of care? And you can clearly see it doesn't stop. Preconception, prenatal, intrapartum, postpartum. But there's a whole purple thing which speaks to preventive medicine. But look at the layer it's on, social determinants. So I'll ask another question because I like being applied in my medicine. When a woman sits opposite from you in the clinic and she's giving you her problems, probably is having hypertensive disease in pregnancy, and you tell her, Mom, you need to have your blood pressure checked, you need to go to the laboratory, we do your uric acid levels, you then need to go and have an ultrasound, and she's staring and the eyes are dilating all the more because she'll ask only one question. I don't have the money to do this. How do I get help? And what have you basically done to her? Thrown her out of that clinic because she won't come back. So please remember, every woman brings her garbage with her, and oftenly it's the lack of. The other thing is strengthening the health system. Rwanda, 4x4. If you don't go together with strengthening my health system, I'll just be a statistic in number. And then primary health and universal health coverage. Now I want you to pay more attention, ladies and gentlemen. I put for you there the asset tracker for medical commodities that are critical for life-saving of women and children. How many of you, and I want honesty in this room, really bother to ask, why isn't heat-stable carbetocin in my facility? How many of us? How many of you have bothered to ask, why isn't magnesium sulfate readily available for neuroprotection? I want to show you, hands. We don't care. We don't care about talking supplies. We know what we're supposed to be doing. The guidelines are there. WHO has given them to you. And we are not even changing our training curriculum and conducting emergency obstetric and neonatal care as mandatory. Actually, if I was asked, I would say every 2 years, before you get recertified for your licensure, you should have that accreditation. But I dream big. The second thing is mentorship. My young and restless here. How many of us bother to speak with them? We tend to bark at them. I'm in the university and I know how we deal with them. How do you create that potential for a leader and not just a clinical practitioner? And then coverage. And when I talk about coverage, I want us to think differently. You can have magnesium sulfate in the cupboard. Has it reached the patient? Answer me. Hello? Has it reached the patient? Huh? It hasn't reached the patient. What do you need to do? Constitute the magnesium sulfate, give the correct dosing, administer it to the patient. If she's having an eclamptic fit, for example. That's effective coverage. But most of us have the drugs there, but it doesn't get to the patient. That's no coverage at all. And then, of course, equity. Now, those of you who like data modeling like I do, you have the health workforce, but the health workforce is in a context. Okay? So, amongst you, the universities are here and the global public health. You're producing these guys. But you must ask a harder question. What's the entry point? How do they enter into the system to work? How do you maintain and even monitor performance? Are they in an enabling environment? And when should they leave? But before that, I must have leadership and governance. I also must have policies. And before that, what's the economics? What's the social legal environment, epidemiological factors? So I want to give an example. I come from a country where we know the coastal area and the western area has a lot of malaria. So I've trained in medical school, University of Rwanda. I've trained how you deal with tropical diseases. But unfortunately, they get deployed in Nairobi. There's no malaria. Have you effectively sorted out your epidemiological pattern of disease? No. So deployment really matters. And politics. Politics. We're in a decentralized health system. Policies are made there, they're supposed to be executed here. Do you have political goodwill? You need to remember this slide, if nothing else. Then I come to the workforce. You've done a very good job, SOGC. You've trained us in emergency obstetric care. But am I available? Am I affordable? Am I accessible? Am I competent to do what you have taught me to do? And the last one, and the most important, and the least dealt with, will I do it? Oh, that breech pregnancy. She has come at 6 centimeters. Cesarean section. Or I'm competent enough as a doctor to monitor and deliver her. Healthy mother, healthy baby. Or like you had yesterday, vacuum delivery. Delayed second stage. Non-reassuring fetal status, fully dilated. Am I willing to do a vacuum? Or now I wait for theater, which is available 3 hours later. So, outcomes. Coverage, quality, efficiency, responsiveness. This is the most important slide for the day. So I said, okay, now let me go and look at how many doctors we truly have. Those of you who are not too far can see. And I compared Africa with outside Africa, and I got a heart attack. I did. Look at all the African nations. The last row. In, what's that country there? I can't read it. Okay, let's take Congo. Okay, Malawi, 1 in every 100,000. That's the gynecologist. DRC, 1 in 80,000. The best was Guinea-Bissau, 1 in 38,000. The gynecologist, huh? That's our availability. Now let's come here, further down, and start looking at the nations outside Africa and globally. United Kingdom, 1 in 4,500. Can you see the difference? When you came to, what's this, Czech Republic, 1 in 4,500. Ladies and gentlemen, really? Even for me as the FIGO president, I was challenged. We just don't have the numbers. So what do we do? What do we do? Health expenditure. Remember my Abuja 15%? So I went to the data, 2021. West Africa is at 14, Nigeria 4%, Ghana 4%. That's what we commit to health workforce. Rwanda, this is 2021, 9.5. I think you're better now. It's only South Africa that's at 15, Botswana and Eswatini. The rest of us have not valued to have money in the health workforce. My best topic. My best topic. If there's anything I'm going to leave here, it's gender issues. Women are the workers. Men are the leaders. Women are the workers. Men are the leaders. We need to change this. We need to change this because if there's no equity, you cannot understand my goals. I've spoken to quite a number of the postgrads and asked why there are more men than women. And guess what they told me? Oh, family will come first. And I appreciate that. For the woman, she has to also have duties at home. But that doesn't mean she can't lead. She can. So, let's come to Rwanda, the topic of the day. Is that one a familiar slide? Hello, countdown 2030. Look at the way you moved with maternal mortality. From over 1,000 in the year 2000, right now I think you're at 203 per 100,000 or 210. I've got two paradoxical figures, but you're in the 200s. Well done. But guess what? You only have 4 more years to get to 2030. So something has to move. But look at the extreme left. I won't break it down, but when you start looking at inequities, okay, we'll say skilled birth coverage, 94%, but there's an inequity difference of 11. So there's what I call the blanket overview and critically looking at what is it telling us. There's work to be done. The population of Rwanda is at 13 million. You're roughly at a fertility replacement rate of 2.3, which is within what is the normal for the global. But work needs to be done. So I went to your public advisory, public workers, and they say, we must promote professional values and ethics in programs and must achieve SDG. So you've had that commitment. Efficient service delivery in NST 1 and more so in 2. Realize economic and poverty reduction with the centrality of what? Read it there. Reproductive, maternal, newborn, child, adolescent health and nutrition. Centrality. So who are the custodians of RMNCH? Who are? Now no one is talking to me. David, aren't you a custodian? RMNCH belongs to us. So you are critical to this government. And economic development and poverty reduction. African Union, the Africa we want, prosperous. Imagine, you've got a very big role. But we need to implement normative systems, training, capacity building, skills development, and relook at our service delivery. Technology, research. So, Rwanda didn't start deflecting on their human resource last year. Last year is when you actually confirmed the 2023 4x4. You started way back. In fact, the more historically I went, the more I discovered more. After your genocide, you brought in community workers. You didn't have any midwives in this country trained until 1997. Imagine. So, you deflected. And you said, we must focus on reduction of maternal mortality and skilled birth attendants and make sure the workforce is there. So, you even set very good targets, and all of them are for 2024 through your strategic plan, number 4. You're already on number 5. But I like what I saw. Maternal mortality reduced from 210 to 126 by 2024. Ambition, but doing well. Neonatal, 20 to 19, under 5, 50 to 35. Health workforce strengthening. You said it very well. We don't want to be at 1 at 10,000, but move to 1 in 7,000 by this year. We're at the end of the year. Increase the nurse midwife from 1 in 1,000 to 1 in 800. Scale up training and retention. And the list goes on. We want universal health coverage with community care at 100%. And then, look at this. Ensure 90% of the population has access to quality health care within a 30-minute distance. You're even better than us with the universal coverage of at least 2 hours. Strengthen disease prevention. The list went on. You'll get these slides. Health financing, you've now reached Abuja, if I'm correct. Ministry of Health can correct me. And nutrition. So you can see you had a very good continuum of care in terms of packages. Infrastructure. You didn't want to leave that behind. And you even went ahead and looked at mental health and NCDs. Rwanda is doing well. But you said clearly, these are the main pillars. Increased skilled birth, training, task shifting and sharing, emergency obstetric care. My Canadians, you're doing the right thing for them. And invest in continuous professional development. Here I'm talking to RSOG, CPDs, RSOG. Then I said, okay, look at the truth. You know, you can tell me nice things, but data doesn't lie. And I looked at your data from 2010 to 2023. It's a busy slide. But what came out clearly for me, your workforce hasn't quite changed. It's a flat curve. The only thing is you've increased a few of the allied workers. This is your data, it's not mine. But community health workers, we have about 45,000 to date. This was as of 2023, before you made up your mind to change modus operandum. I went to health facilities. What are you doing? Because we've talked about deployment. Where do you take the doctor after they qualify? And I realized what you've increased very well is health posts, private dispensaries, private clinics. And I said, Rwanda is going to go the Kenyan way if they're not careful. How many beds do you have in a hospital? Up to 2022. And I realized most of your beds are actually in the health centers. So you're doing very well with primary health coverage. That was my conclusion there. Then I went to your regulation because we're all guided by the normative, the policy environment. And I said, financing, tick. Emergency care, tick. Surveillance from RBC, tick. But where's the health workforce? At 40%. This is your data, not mine. So you remember this graph? Do you remember it? My modeling. So I went back to model for you. And I will not expound on this, but I'll give you the game changer. The what? What am I giving you? Game changer. And all of you have to learn today. The Human Resource for Health in Rwanda has taken up a key initiative that aims to strengthen the workforce in this country. Remember, I'm on a flat curve. What am I going to do to change that? So, in 2023, in the month of July, you took that path and you said you want to quadruple health workers within the next 4 years to achieve the WHO recommendation of at least 4 health professionals per 1,000. In fact, WHO says it's 4.45. To date, we only have Libya, Botswana, and South Africa that have met this. So what did you say? We want to reduce maternal mortality. We want to achieve universal health coverage. And we must strengthen the health workforce. How? Strong, competent, motivated workforce. But to also include addressing our challenges, context, communicable diseases, non-communicable diseases, and health emergencies. Can you see our context? Does it resonate with you? I think so. So we modeled this, and we said data is going to inform us every time. So I went ahead and did the modeling for you and put in the statistics that actually inform the Rwandan healthcare system. And lo and behold, that's the formula. This is the trajectory you're going to go on. Can you see? So my maternal mortality should move from 210 to 203 by 2050, where Rwanda says they want to be a high-income country. You are way below that 70 mark. And if you save a mother, you will also save who? Who else will you save? Hopefully. You save a mother, you save who? The baby. And you save the husband. Now, I'm being honest, additional interventions you have asked yourselves that you must do is to increase ANC to 90%, improve your referral mechanisms, and then relook at supply chain, technologies, and data analytics. Can you see what you've decided? I want you to learn. And how are we going to do this? Because everything must have a how, implementation. Training and education, infrastructure. Put concerted effort on retention and motivation. RSOG, you come here again. Task shifting, reform, management. And here I want to speak to leadership. We must be in the driving seat to lead this process. Who are targeted? Everybody. The doctor, the nurses, the midwife, health managers. And you have committed to have a health workforce of 32,000 plus personnel and quality of service. We want to do this through who? Partnerships. SOGC, now you understand why you're here. Partnerships and innovation. International institutions. Capacity building. Training and education, health system, sustainability, and local ownership. That's what you want. Don't focus on all of it, it's a busy slide, but look at the bottom. This is actually an infographic I picked out of your 4x4 reform, which clearly says we want coverage, we want improved quality, we want maternal mortality decreased to below 70 per 100,000, and by 50 per 100,000 by 2050. We want reduction of neonatal mortality to less than 11. We want geographical equity. So those people on the 1,000 hills at the top, they shouldn't be left behind. They must get access. It will give you life expectancy that will move from 80 years to 90 years, prevent 41% of non-communicable diseases, and curb the under 5 mortality. Very good. Impact. For everything you do, there's an outcome, there's impact. Medical workforce growth, quality, health systems, sustainability. But there are other things the Ministry of Health is doing, and doing very well. They're still addressing their revamping of the community group, hospital accreditation. Nobody has reached level 3, but I'm aware that you have level 1 and level 2. So we need to push to level 3. International benchmarking. Now this is where my global public equity vice chancellor comes in. We have to benchmark so that you get the best of the best. RSOG, where are my partners? FIGO is there. You're part of FIGO. You can't benchmark any better if you're not affiliating with all the bodies I work with. It is important. Other things, and Ministry of Health, correct me. You have already gotten medical equipment with an MOU in Egypt, North-South collaboration in Africa. You have expanded emergency services with new ambulances. You have a South-South cooperation initiative with Africa to the Caribbean. ICRAD is in the house. You're there? I can see where you are. With minimal invasive surgery. BioNTech, what are you doing? You're producing vaccines, hopefully. You'll have therapeutics and medical products. So how much more should RSOG say life-saving commodities for women and children is a priority? That's where you're going to come. And I'm sure you'll be called to those meetings, hopefully, to give your voice. But I said, okay, reform 4x4. I have 4 per 1,000 in place. But because I told you I'm a dreamer, there's always room for improvement, to create, reimagine, discover. And I said the first thing I want to see added here is the interrelationship between public and private practice. King Faisal, you need to be engaged in this conversation. Blended financing programming. Strengthen South to South. I'm very impressed with the 4x4. And the first thing I said is, I either move to Rwanda, because they're going to open institutions for me to train you guys, or I work with Rwanda in the 4x4. But we need to pull each other up, South to South. One government policy, one health. That's a very key area. Health sector has always talked to itself. And we're saying women are complex entities. You need to talk about agriculture and food, financing and small medium industries for them. You need to talk about education. Keep the girl child in school because it has a bearing on her social determinants. So, Ministry of Health, where are the other line ministries you're working with? Number 2, and more importantly, you will have pooled financing. Domestic financing can come up very easily. Use of technology and tools and innovations. How many of us have got smart watches on them? How many of you? Hello? Smartwatch. I know how many steps I'm making in a day. What's the minimum requirement? Huh? 10. 10,000. At bare minimum, 7,500. So all of you are unhealthy. All of you. Unhealthy. If you can't monitor what you are, then you certainly don't know who you are. And we're moving to self-care, which is something else I really want to bring to Rwanda. Self-care as a primary health intervention. Future supply, it's not just about rolling out doctors. Please, also look at my demands as a doctor. It's a two-way traffic system. More importantly, I want to be fit for purpose for the global world. Today I'm in Rwanda, tomorrow I'll be in Canada, hopefully. Or I'll be in America, or I'll be in Australia. Am I trained adequately and proficiently to go? And even to come back, because there are those in the diaspora, like my friend here, keep picking on you, because I want you back. Yeah? Those in the diaspora will have an attractant to come back home. Why do they stay out there? They should be here. The other thing is looking at health as an enterprise. Ministry of Health. You need to have a competitive edge. I want to see Rwanda become the place where I can have medical tourism. Why should I go to India? Enterprise modeling. You must enterprise model. You must have profit pool modeling. And you must concentrate on self-care. He's taking notes so he knows. The other thing is my women. My women innovate with me. New market approaches. I'm the one who knows best. I want to speak to something, and I really want to talk to my representative from Global Health Equity. We have supply chains of health products. But I was looking at the Rwandese training program where people can speak to that life-saving commodity and realized we have a gap. We have a gap. Pharmacists are there. Doctors are there. Where is the interface that speaks to what is really needed? You are now in BioNTech. So this should be something that we should really actively look at. And this is what I'm calling specialty pharmacy care. Integration, modeling, service points, self-care, and even now the predictive and precision. My oncologist is somewhere, yeah? And targeted care. Understanding the intersection of our supply chain. So I went to data. What is our education program in Rwanda providing? It's a big gap. We have short training courses, no SCM, limited procurement. Have a look at this. This is something you'll need to address. And then I like this one. I want to model health differently. The next generation is restless, but they want the money. But they don't have the patience of my good friend from King Pfizer of 50 years in practice to get the money. They want theirs in 5. So how are we going to model for them? And this is something globally we are looking at. If those of you who want to really read on this, go to McKinsey reports. That's where you'll get this information, right? So what's your geo footprint with these young ones? They don't want to go. Give me the most remote rural village in Rwanda. Which is it? You know it better. But no one wants to go there. They want to be urbanite in the city. Self-care becomes a really major area. Then software modeling. For the longest, we just talk about health in health. Output, outcome, impact. Now I'm telling you, use AI and modeling and the language modeling across sectors. I like being practical. In Kenya, my young girls undergo female genital mutilation in some of our communities. Immediately after that, she goes into motherhood. So she drops out of school. And when she drops out of school, she never sees that classroom again. I'm seeing, thank you. She never sees the classroom again. Are we speaking to Ministry of Education? Are we looking at the trends of our adolescents and teenage pregnancies and what impact it's going to have nationally later? That's what I'm calling the language modeling. Then the challenge of the market. We must be real. My good friend here doesn't want to come back because he's saying the money out there looks very nice. Why should I come back home? But Rwanda needs you. They invested in you. Isn't that the truth? They put the money down for you. So why are you going out there? So what are you going to do as Ministry of Health to keep us here? So the other thing is technology. And I'm a little bit selfish. In fact, let me go back. Please read this paper, The Femtech Revolution. It's a FIGO paper. I'm one of the publishers there, re-looking at what do we do when the health workforce isn't enough. You must bring in technology and go into hybrid medicine. And if you want me to even be honest with you, telemedicine is cheap. Data analytics is really picking up, and that's where the money is. But you must begin to rethink what is primary health, what is self-care, when should you see the doctor, whom should you see, so that it is cost-effective and has some direction for all of us. Planning based on data, scaling up, role of technology. And here I put it differently. Does anybody know who that girl in the middle is? Do you know her? She has my name. She's called Anna. So you log in and you say, Jane has got 1, 2, 3 problems. And Anna will tell you, ma'am, she's a low risk. She can be seen at a primary health center. So you free the obstetrician and gynecologist to see high risk. So this is how far technology has come. We have 2 of them. There's Sarah and there's Anna. Anna is being developed by a young doctor, where he's saying clerkship, triage, filtering for risk assessment can be done by a robot. So, ladies and gentlemen, if you're not subspecializing, your days are numbered. We're going to have robots with us. Analytics, I can't overemphasize. I think you've seen what I've done. So I move to the last part of this presentation that is critical, the role of RSOG. They know themselves, starting with Victor. Please, you should be part of the leadership in empowering health workforce. Formulation and reviewing of the normative environment. Optimizing competencies and motivation. Assess and repackage the graduates we are releasing. Please provide specific women strategies. I'm very keen on this, starting with baby creche. Keep abreast of introduction of technologies. Forge towards universality, diversity, equity, social inclusivity. Cooperate with state actors, he's sitting next to you, on human rights-based approach. Your voice and agency matters. We must engage in women's health research and for the women professionals research. We must value women, avert disease and disability, but above all remain accountable. That's RSOG. My last slide, or second last. Empowering the woman professional and allies. Allies are the men in women's health. Please give women an opportunity to lead. Gender parity in the health workforce, not just as workers, but as leaders. Strengthen our voice and agency. For women, you need to pick them up because culturally, we're in a patriarchal system. Please hold our hands and put us in the front. Conduct robust R&D. And finally, women must engage in the development agenda. What is important for all of us to know, we know where our shoe bites. As a professional, as a mother, as a sister, as an auntie, as a cousin, we know where our shoe bites. Give us a chance. Only the wearer of that shoe knows when the shoe is pinching them. With that, I'll say thank you and say this. The joy of motherhood changes the trajectory for generations. For generations. Upholds and builds families and drives sustainable development. We are the health workforce that matters to ensure that this happens. It needs us to do what? Step up, step out, and our accountability. Thank you. Thanks.
Thank you, Professor Ann Kihara. That was amazing, a great start. So we're going to jump right into our first panel. And I'd like to invite our moderator, who is a co-host with me, Dr. Magnifique. Thank you. Give him a round of applause.
Thank you very much for such a great and inspiring keynote speech. And I'm actually going to answer to the assignment. We've been challenged to think and work on self-care. And I think we better start now. So please stand up as we work on our first self-care assignment. So you go after me. We'll try to touch the roof and then touch the ground. Let's go, touch the roof, everybody. Get there, please, let's see who is tall. Please. Okay, let's touch the ground. Get there. Thank you so much. You may be seated. It's been a year and 2 months, 14 months exactly, when the 4x4 model has been launched in our country. From the inspiring and very, very nicely put keynote speech, we've been told that from 2012 up to 2023, we did not move the needle. However, the country, with the leadership of the Minister of Health, they said no more. We need a new strategy, the 4x4. Americans would say that the devil is in the details. The great, well-put program, one single detail can be a problem. I was given a great job today to ask questions. And I've got few questions today. Are we living up to the standards? Is the quantity matching the quality? Is the skill given matching the competence? Good thing I'm asking the questions. But I've got great panelists who are going to answer those questions. So we're joined by the head of department from the Ministry of Health in the Department of Health Workforce, Dr. Menelas. I would like to invite him to the panel. Please give him a round of applause as he walks to the panel. And as I speak, I'd like to have the IT people try to put up the bios so that people know exactly who we're talking to. Next, the principal of College of Medicine and Health Sciences from the University of Rwanda, Professor Abraham. Next, Prof. Abebe, who is the Vice Chancellor at the University of Global Health Equity. Next, Dr. Mivumbi Victor, who is the President of Rwanda Society of Obstetricians and Gynecologists. And last but not least, Ms. Kwahirwa Luange, who is the Deputy Director at the Health Development Initiatives. As I told you, my job is really nicely and easy because I'm only here to ask questions. And I will start with Dr. Menelas. The government of Rwanda, over the last 30 years, they have done an amazing job. We've managed to cut the mortality rate. We've managed to work in all spheres of health. I would like to help us and navigate through the last 30 years. How did we get there? How did we get here in the first place? Can you please tell us how we've achieved and how we've succeeded in the health sector over the last 30 years? Thank you.
Thank you very much. It's a trip in the past. So as some of you know it in the room. 30 years ago, that was right after the genocide against the Tutsi. The country was being run by 30 medical doctors, only 30 medical doctors, who were able to, with their peers, allied staff, mostly the collaborators were from international humanitarian missions. We all remember the Australian Brigade, which was running Cervical and other big hospitals in the city. So they worked hard to try to stabilize the situation, and it was a crisis mode. And if you take the 30 years, we divide them in 10 years blocks. So the first 10 years, that was a crisis. You do what you can, what you're able to do. Are you available? You do what is within your means of doing. And the second portion of the 10 years, it was the primary healthcare trying to take some shape. And this last portion of the 10 years is trying to sustain the gains. That's where comes the, am I able to vaccinate at this high rate of more than 90%? Am I able to make sure that people are delivering in health facilities and attended by skilled health professionals to keep them above that 90% that Professor Anne-Beatrice correctly presented. And this figure, they might not sound good because of the needs of today, but they used to be zero. They used to be zero. We moved from zero, from scratch, but you get somewhere we want to stay. But of course, that's not the end of it. So mainly now we are more of looking into upgrading the standards, and this goes with heavy investments, not only in subspecialty care, but also there is a lot happening also at the primary healthcare level. And who knew, actually, I always feel amazed when I speak to colleagues, especially in the most subspecialized areas, maternal-fetal medicine. I tell them, like, who knew you can be able to detect these tiny things of unborn babies and even do surgeries and even transfuse. This is something that we could never think of in the years that have gone. So that is built on very strong political will. We understand that health first, because only a healthier nation can prosper. So there's a very strong political will driving all of this.
Thank you so much. That's very well put. I'm going to request you for one thing, please. Can you please take us in a flight? Please fly us to 2018 and tell us, is really 4x4 real? Or is this beautiful document? I've spent a lot of time reading this beautiful document. So we need to leave this room actually thinking, is this real? Or is it just like going to be a nice document that is going to go in a cupboard after 4 years? Please tell us, what's going to be 2018 like?
For sure, it won't be just statistics. I know we say we have one skilled health professional per 1,000. We envision to be at 4 per 1,000 by 2028. So we believe by then every doctor who is in this room, they will be able now to work within a practical, they will have workloads that are flexible and practical. Because I know today everyone here is in the job profile or a workload that's supposed to be done by 4 people. But we stretch them in different directions, but that is temporary. We are almost there. And I very much liked to what Professor Anne-Beatrice said, we have to hybrid medicine. So I just put it in bold, actually put it in my office, that there are things that you need to do when you are short of staff as a temporary measures, as you walk yourself towards where you want to be. We have more of improved working environment, that's infrastructure that are new to accommodate new programs, those that are innovated, upgraded equipment. There are more and more fancy things that within a click or within a scan, you get information in a way that is AI enabled. You have well-tailored professional career growth, and this system will continue to make sure that the health professionals are able to attain the highest stream in areas that is of their great interest. We look at more empowerment, fulfillment, validation also is very important. Validation not only within the region, but also globally. So all of these are very well captured in our health sector strategic priorities of 5, the version 5, which is available. We will share with you. We make sure that we are where we need to be. Thank you.
Thank you very much. I'm sure on that flight to 2018, we've got 2 pilots, and both of them are the people in the academia. So my first question, which I think both the panelists in academics are going to answer, are we going to make sure that the skill is matching the competence? Are we making sure that we keep the quantity, but also the quality? What are the mechanisms in place to make sure that the trained physicians are up to the standards? Prof. Abraham and Prof. Abebe, please take us through that.
Thank you. Let me start from the questions that you threw to Dr. Menelas. Is it happening, the 4x4? It is happening now. If you come to University of Rwanda, which is the only public higher learning institution in the country, we started implementing 4x4 immediately. It was first discussed, I think, March 2023. By June, we increased the number of our students. So it is already happening. If I give you numbers, in undergraduate medicine, we used to have not more than 100 students in a cohort. By now, we are having 400 plus students in a cohort. In nursing and midwifery, we used to have less than 200 students in a cohort. By now, we are having about 1,000 students in a cohort. This is across all disciplines that University of Rwanda is running. The same is true in postgraduate study. Now, the issue is, you raised issue of competency of those candidates. What strategies are in place? In the previous discussion, it was said that there were initiatives tried before, but they didn't go as expected. I a bit disagree with that. The foundation was laid by them. And it is, we are basing on that foundation, for example, capacity building of University of Rwanda on biomedical sciences, clinical facilities, and so on, were laid on that. What we did is just, we analyzed the situation and we jumped up so that we can accommodate to this level. So the other strategy, what we used is, rather than localizing our students to the usual teaching hospitals, we went to the secondary level teaching hospitals so that our students have better exposure. And it's not only sending students, we recruited faculty with partners and deployed them so that they are taken well. The other strategy, while we are increasing the numbers, especially in undergraduate education, we didn't simply increase in one batch. We divided them into 2 intakes. The numbers which I told you, 400 in medicine, 200 of them are in the first intake, and the other 200 6 months apart. So that way, we try to minimize the impact on quality. The other strategy is, which used to be said, partnership. We are working closely with local, the internal or Ministry of Health, teaching hospitals, and the university. We are working together as a team, and partners from all over the world that are mobilized and working with us. So that's the way. If I take you to this topic in gynecology obstetrics, in the previous years, we used to have not more than 25 residents in a cohort. This year, we are having, as you know, 64 gynecology obstetrics residents. But we didn't keep them in the usual hospitals. They are distributed in district hospitals, secondary level teaching hospitals, where they are being taught by relevant people recruited through partnership. Thank you.
Thank you very much. I think that's great. I really, really think that's great. And but before I get Prof. Abebe, I want to also learn two things. Yes, on the quality, skill matching the competence and quality. I also want you to touch on the experience. We've seen the UGHE just graduating their first cohort of medical doctors, which is a huge milestone, really. But then how do we learn through that journey? How do we use those lessons learned with that and actually feed into this new model of 4x4? And again, how do we match the competence and the quality that is needed? Thank you.
Thank you. Good morning, everyone. If we try to demystify those two words you used, competency and quality. Competency is a job description. What are gynecologists in Rwanda? What are they expected to do? Whoever is hiring them, giving them the license to practice, probably has a list of activities. These activities are categorized under knowledge, attitude, and practice domains. These make up the competencies that we talk about. I think quality starts from there. Do we understand what, for a second, let's forget the title of gynecologist obstetrician, this person who's supposed to do this, and how do we call them? Quality starts from there. Now, when you link this to quality, quality comes within 4 pillars in academia. First is intake, processes, and output. How do we select our trainees? In medicine, nursing, whichever health professions education we are talking about. You cannot get a perfect 12th grader to bring to a medical school. It starts from high school or elementary school. We need to have a system that prepares young people for health professions education. May take a few years to do that, but since grade 6 or grade 7, how do we encourage young people, boys and girls, to be prepared to enter medical school? Then how do we select the most, shall we say, the most prepared ones? Is there a selection process? Or if they just pass the high school exams, they just enter medical school? How do we select them? That's intake. Second is process. Process starts from curriculum. Curriculum is a piece of paper. I don't think we should put too much emphasis on what curriculum is about. It's the curriculum implementation that matters. Now, once you have a curriculum, how are you teaching them? And who's teaching them? I think many of the doctors are really good doctors. People who taught me, who worked with me. I also consider myself as a good surgeon. But that doesn't make me a good teacher. It stops there. I'm a good surgeon. It ends there. To be a teacher in medicine, you need to be trained to be a teacher. Our profession has completely ignored this fact. Go to high school and elementary school. There are mathematics teachers, competent in mathematics, in biology, in chemistry. But they're also trained to be teachers. This is a movement towards quality. So in the 1980s and 90s, many medical schools in the world has adopted the principles of health professions education training. How many of us are trained in teaching in clinical setting, in simulation, in laboratories, in setting up good MCQs, setting up good OSCEs, in mentorship? So the way you train, your faculty and the way you make them ready to teach defines quality. Second is the third is the environment. Where are we sending our students to? I mean, human resource for health development is a marathon. It cannot be a sprint. If you want to appreciate Harvard now or Oxford, it started 400 years ago. So we should probably move away from this misconception that within 3 years we are going to create heaven in Africa. No, it doesn't work like that. We need to calm down, plan, and take steps every day. Then the final is the output. Let's say University of Rwanda, UGHE, and other medical schools are producing doctors every year. But are they ready enough to enter the workforce, to be registered? The only stopgate you have between trained doctors and the population is an exit exam. There should be a gate that says, oh, you are safe enough to treat Rwandans or Africans. That assessment, progressive and summative, should be there. So this is what quality is about. It's not so complicated. If we separate the steps, you can easily get there. Now, as far as UGH is concerned, well, we try to focus on some of these things. A certain selection criteria, selection teaching approach, assessment, and they are deployed. They probably will graduate the next year, December 2025. We are strong supporters, believers of 4x4. Very strong believers. And we want to be partners to the Ministry of Health in the quality assurance front. Thank you.
Thank you so much. And the audience, please make sure if you have anything, write down, because I'm going to open the Q&A for everybody. Prof. Abebe just touched something very important, President of RSOG. He said that the curriculum is not what matters. What matters is the implementation. And here we land on the professional societies. We've got you here, we've got the anesthesia, yesterday we had physicians, we've got most of others. So how is the society ensuring that the implementation is up to where the academicians are actually telling us? Because they're going to set great programs, but they need everybody. He also said something, that being a surgeon doesn't guarantee being a good teacher. So being a gynecologist doesn't guarantee being a good teacher of gynecology. So what's the society doing, and what do you think other societies should be doing?
Yeah, so thank you so much, moderator and colleague panelists. So first of all, I want to emphasize current role for Rwanda Society of Obstetric Guide in this program 4x4, where we are in collaboration with the ministry and the UR. So as you know, this program is an initiative from the ministry, and it is there with intent to tackle issues of reduction of maternal mortality. So we all know that the issue of human resources is very key, and it's across. So with this very initiative from the ministry, so RSOG has been engaged to commit and coordinate this program of residence, a hospital residence program with UR. So initially, we were able to ensure the quality. How? The first things we had the thought was really to establish the ratio of faculty and residency. Make sure the ratio is really comply with the standard. So this was really a big role for the society, whereby we had staff in collaboration with South colleagues from different countries. So in terms of making sure this quality also continue to be sustained, so we were able also to establish, using the existing faculty, gynecologists who are in the teaching hospital, but also who are even based in those hospital, level 2 teaching hospital. So we create a pool of gynecologists to make sure the continuous education by providing mentorship. So in the supervision. This is, I think, response to the question, because even though we have those faculty who are based in the hospital, but also the society want to make sure that during the training, the quality and the standards are being met. So that's why we have the involvement of the society to mentor and then to go on the ground to make sure that the quality is being provided at that level. So this really we make sure that at the end of the program, those students, residents, will be able really to provide the quality of services. The other point is discussing with the ministry and then advocacy of how to maintain our residents after completing this program. So together we are also thinking how we can put strategies to really maintain our faculty residency so that they can stay in those hospitals. So this is a very big discussion and the collaboration between University of Rwanda and also the ministry. The other point for the society which we are doing currently, we are making sure that we are providing the standard and the quality tools to be able to conduct research within the location where our resident is based. Because we started in April, but we have in advance the plan to avail those tools. The other point we have in our mind is the implementation of telemedicine. We want to collaborate with some of the international organizations like a Proximi to make this telemedicine being implemented also and make sure different localization of this program are following the same quality of education. So I'm saying this because I feel it very important to make the program really success, but again, I'm looking for other collaborators like SODC, but also Johns Hopkins University. We are together so that we can have different collaboration and also actors to come to support this program. So making sure that we have the standardization tool globally to make sure that our future resident students will be bred with really acquired skills and the competencies. Thank you so much.
Indeed, that's great, that's great. We might be a subspecialized country, but we know that the grassroots is the community. I would like to bring in someone from the NGOs and government organizations. The government is trying to do everything to make sure all the partners are on the table to discuss teaching and health workforce strengthening. So I would like to ask from the civil society point of view, what are we doing in the community? How are we making sure that we are actually making sure that they are also trained, they get a level of training, and the specialists also understand it's not just like the disease, but the person. Thank you.
Thank you so much, Magnifique. I will start by saying that community education and training of healthcare providers, it's interconnected because well-trained healthcare providers are able to train the community through community education. And in return, the community education raises awareness. Once the community is aware of the available services, it empowers them to make informed decisions. Coming back to the human right-based approach that was mentioned earlier, it emphasizes that the community should claim their health rights. And how do we get there? How does the community claim their rights? It's through the education. So it also builds an accountability mechanism. Once the community is aware, they are able to make sure that the healthcare providers are providing the right services and that those services are of quality. That is a basic human right. So I believe that training the healthcare providers does not stop there. It requires that we go down to the community and ensure that the community is aware of the services and they are able to use those services. So as HTI, we are strengthening the community outreach together with the Ministry of Health to ensure that once the health system is strong, sexual reproductive health and women's rights are at front and the community is able to use these services. Thank you.
Thank you very much. Can we give our panelists a round of applause? Aren't you inspired? I am very inspired. And actually, I have to come forward. I am a strong, strong believer of the 4x4 model. And I think it's actually one one of the robust solutions that we're going to have on our system. I read this a lot because I believe through this we are going to change our health system. Something transpired yesterday in the opening ceremony. And I worked with our IT team to have a 50 seconds video played. Please, IT, don't disappoint me. I'm sure we have that. Let's hear this, and I'll come back to the HOD.
Council, this is a legislation body which guides us in all things we are doing. So we do recognize also being here. I also want to recognize...
definitely not this, please, IT.
It has been really amazing team. That's why you are seeing all those people here. It took us, I think, a year to ready to do preparation for this.
I can tell you that it's on the 7th hour, 40 minutes, and 01 second, to remind you specifically.
Dental Council, this is a legislation body.
Oh, as you're preparing for that, please keep working on it. Let me open up the Q&A for our audience. Does anyone have a question? I'll probably take 3 to start with. And does anyone have a question they would like to ask to the panel? Because I asked you to contribute. Yes, we have a hand. Do we have any other person who wants to contribute? Can someone help me pass the microphone?
Thank you very much. My name is Dr. Cyprian. I work for Partners in Health. I'm in charge of the oncology program. So I will address my questions maybe to Victor or to whoever wants to take on this one. Since we are talking about training of healthcare providers, it is very important to, to go through this formal training, academic courses. But from my experience, it is also important to also have plans for continuous professional education. There are, training modules like, is it Sony or whatever? So in the past, we used to make sure that all the doctors, including GPs, okay, before all, as they work in district hospitals, we make sure that these courses are organized for all of them. I remember Professor Maurice, the first session I had on those courses was with him. So is there a plan to make sure that our GPs or our young specialists are able to follow those courses to make sure that they are really confident when they do these cesarean sections in the district? Is there a system actually to monitor, to follow them after the graduation? Thank you very much.
Yes, you can go ahead and answer the question.
Yeah, so thank you so much, Dr. Cyprian. This is already a good question because we were talking about the program, undergraduate and the postgraduate program, but we do believe also we have to have some competencies program to tackle off the current issues. So he gave us an example of completing some of the EMOG or RSO or ETAT program after completing the undergraduate. So exactly, we have observed together with the ministry and the other partners, some of the gap after completing the undergraduate program, whereby some of the students are not able to conduct some of the intervention, for instance, self-cesarean section. So then I feel really it's important to think about it, but also to have a plan. Currently, we have a plan with, in collaboration with the ministry, UGHE, to run a cesarean section program for young graduates to make sure that they have those skills. It's not only on the cesarean section, but we want also to add a kind of management of obstetrical complications before they go to start implementing in those hospitals. Because we have seen some of the, I will call it gaps, where a assigned doctors young is not able really to accomplish because he didn't really be exposed during the training. So that's why we have that plan, that gap which have been faced during pre-services to come up with in-services training. So the program is there. I think that's what I can say. And if colleagues can add, please, you're welcome. Thank you.
Thank you. The fourth pillar of quality I did not mention earlier was post-training quality assurance. It's exactly what you mentioned. Licenses should depend on current competence, not competence 10 years ago. So that is why regular CPDs, regular training improvement, competency improvement programs should be there. And I guess that's where the country is going into. It's just a matter of time, but it will be there. Remember, 4x4 is a very bold plan. It's a very ambitious, very bold plan. It's quadrupling the workforce in 4 years is really, really huge. So if there are teeny tiny issues here and there, I don't think we should be discouraged by it. We should first appreciate that such a bold decision is made. It's going forward. And along the way, it's better to do whatever we can to support it. When we come to the cesarean section training mentioned by Dr. Victor, that's part of post-service CPD. If I'm correct with the data, more than 60% of cesarean sections in Rwanda are done by GPs. Right. The number may be very high. But do we honestly teach our medical students or our interns to do cesarean section while they are under our direct observation? I'm not so sure. They learn on the job. They become GPs. They, attach to a gynecologist, learn on the job. But can we make it better? Can we build competencies, EPS, to this training? That's what this consortium is trying to do now. Can we train the GPs better so that they can achieve these goals better? Thank you.
Thank you very much. I have one more hand, but before we play, can we have the video, please? IT.
Rwanda, you have embraced the 4x4 reform strategy from last year, quadrupling the health workforce in the next 4 years and leaving nobody behind. However, that's where now you put the gap. We need to pay more attention to the provision of an enabling environment. Ministry of Health, I really want you to listen to this. I am a gynecologist. I report to work at 6 a.m. I don't leave until my night duty is over, which comes at 8 p.m. I don't get a cup of tea. I don't get lunch. But I'm human, and I'm yet to still do those surgeries.
Here's the question the doctors are asking. What's in for us? Is the 4x4 going to end up with a doctor's health also taken care of? Or they are going to be homeless, struggling, not eating, and be asked to provide a quality health care? Then, through the words of someone else, not me, I'm asking that question. HOD, what do you tell us?
Well, using Professor Anne's example, actually I can maybe summarize in a way. Remember the story you said, fetching water, coming back, how we are lucky. So that's a true reflection of you are challenged but not overrun. Because if you are here, it's because you could accept those challenges. And it does not stop us to keep working on ensuring that you are trained, you are accessible, available, but also affordable. And we understand that all of that is very needed, and it's a matter of when and why. This 4x4 has taken care of all of that. It's not a very big amount of money in terms of cost. It's only 400 million USD for the next 4 years, but make sure that it's distributed in a way that give room for those enablers as well.
Thank you so much. Oh, and what about the doctors? How is the, because I believe actually, when I read through this, because I had to prepare, when I read through this, it talks about retention. And I'm sure you can catch on that just like a few seconds. I'm sorry to put you on the spot, but just asking because the doctors are asking. What do you think about that?
What specifically you want to, can you rephrase simply? Keep it simple.
Prof. Ann is asking to rephrase a little bit.
You are providing a supply chain of doctors. We're asking our welfare in provision of service, the demand side from the doctor. I just gave one example. My basic needs are not met, yet I'm supposed to be operating at my best potential. So our welfare, to keep me actively contributing to what MOH desires.
Well, I don't think I will live here anytime. Maybe to rephrase again. Let me try again. So 4x4 reform is it's one of the 5 reforms that we released actually in July. At the same time of 4x4 reform, there are other reforms that I'm going to mention, and I hope you understand that it's all plugged together. There is primary healthcare reform. This we work on the community level to ensure that some of these roles are relocated to be done by someone else. That's the PHC. We have a 5th community health worker who is IT enabled, able to do things that were being done by some other cadre. We also have strategic acquisition of equipment and medicine. I think you mentioned something with Egypt. It's bigger than that. So the working environment is changing significantly. So it's not only Egypt, but there are many other players involved for equipment, distribution, equitably distribution of the equipment, and also the medicine as well. So that's two. There is modernization of emergency medical services. It's also part of that. And there is the last one that actually we worked on, at least most of the people in this room, I remember being part of it, is the welfare reform. We might not have pushed the button, but at least we understand what we understood and agreed on what needs to be done and when in the first approach. So I hope that all captures that we are not looking at the numbers, but also strengthening the health system in general. Victor, do you want to add on that?
Thank you very much. We have 1 minute, and I'm actually, before Dr. Victor says, I want to, as you say, I want all the panelists to use one word, like Victor, for example, I'm sorry to use the name, of what you think this 4x4 is going to be. One word in a minute, then we have to give the time, as you can see that. Go ahead. You can answer the question, but also
exactly.
say one word.
So I want to add something, which I know because we collaborate together. I know there is at the ministry a request in regard with this welfare of healthcare workers, including also incentive. But the incentive is not only salaries, but there is other aspects which are working on. And then I know that Minister Sabe has started discussing with high level, Minecofin, to see how to increase some of the incentive, avail houses, but also making sure on the work environment they have some of the spaces, maybe friendly hospitals, it's being on the table to discuss in the future. So this is one of the strategies linked with the 4x4 reform. Thanks.
One word. What's your one word? What would be your one word that would describe or reflect to 4x4? Like me is result. My word is result.
My word is making sure that we are reaching the 2015 NCS2 by reduction of maternal newborn death, because I know the current issues really which is not helping us to reach the SDGs is this number of staff, capable staff who are able to provide the quality. That's why the 4x4 and the collaboration together, we are here and able to contribute. Thanks.
Quality as the one word. Keep it going. One word.
One is not enough. Give us more. I would say that once we implement the 4x4, let's not forget community education. It will be for no use if the community is not aware that we have stronger health systems.
Community.
Partnerships.
Partnerships. Great.
For me, yeah, I would repeat partnership for better production.
May I use two?
Yes, go ahead.
One is bold. Second would be quality. We should never forget quality.
Amazing. Give them a round of applause. Thank you so much. You may go back to your seats. Thank you so much for joining this panel. That was a great first panel. And as we've spoken about self-care, let's get something in our stomachs so our brains can start working again, yeah? So we're gonna have a quick coffee break, and you may have coffee and a little snack outside, and then come back inside for us to proceed. Thank you very much.
Welcome to Mega Life Sciences, established in 1980 and a public company since 2013. With a global presence in over 33 developing countries, and GMP approvals in over 50, Mega is a leader in the health industry. Mega Life Sciences has proudly served the people of Rwanda for over 9 years, supporting health and wellness in the region. Our manufacturing plants span across the globe, ensuring the highest quality products for all. At Mega, we believe in helping people stay healthy as long as they live. We are passionate about women's health and focus on developing brands with the modern woman in mind. During pregnancy, nutrition is key, but diet alone may not be enough. That's where Mega Prenatal comes in. Small, easy-to-swallow capsules packed with essential micronutrients for a healthy pregnancy. Ferritone offers a breakthrough liquid in a capsule formulation, eliminating metallic taste and GI irritation for easy, assured iron absorption. Calcivita's small, vanilla-flavored capsules ensure optimal calcium absorption without digestive discomfort. For fast relief from pain, Gofan's unique clear cap technology delivers results in just 15 minutes with minimal GI irritation. Mega's portfolio includes a NAT 400, the purest form of natural vitamin E, Zeman for enhanced testosterone support, and a NAT cream for flawless skin with reduced stretch marks. With a wide range of innovative products, Mega Life Sciences is committed to your health and wellness, wherever you are.
Mega, we care.
Welcome to Mega Life Sciences, established in 1980 and a public company since 2013. With a global presence in over 33 developing countries, and GMP approvals in over 50, Mega is a leader in the health industry. Mega Life Sciences has proudly served the people of Rwanda for over 9 years, supporting health and wellness in the region. Our manufacturing plants span across the globe, ensuring the highest quality products for all. At Mega, stay healthy as long as they live. We are passionate about women's health and focus on developing brands with the modern woman in mind. During pregnancy, nutrition is key, but diet alone may not be enough. That's where Mega Prenatal comes in. Small, easy-to-swallow capsules packed with essential micronutrients for a healthy pregnancy. Ferritone offers a breakthrough liquid in a capsule formulation, eliminating metallic taste and GI irritation for easy, assured iron absorption. Calcivita's small, vanilla-flavored capsules ensure optimal calcium absorption without digestive discomfort. For fast relief from pain, Gofen's unique clear cap technology delivers results in just 15 minutes with minimal GI irritation. Mega's portfolio includes a NAT 400, the purest form of natural vitamin E, Zeman for enhanced testosterone support, and a NAT cream for flawless skin with reduced stretch marks. With a wide range of innovative products, Mega Life Sciences is committed to your health and wellness, wherever you are.
Mega, we care.
Welcome to Mega Life Sciences, established in 1980 and a public company since 2013. With a global presence in over 33 developing countries, and GMP approvals in over 50, Mega is a leader in the health industry. Mega Life Sciences has proudly served the people of Rwanda for over 9 years, supporting health and wellness in the region. Our manufacturing plants span across the globe, ensuring the highest quality products for all. At Mega, we believe in helping people stay healthy as long as they live. We are passionate about women's health and focus on developing brands with the modern woman in mind. During pregnancy, nutrition is key, but diet alone may not be enough. That's where Mega Prenatal comes in. Small, easy-to-swallow capsules packed with essential micronutrients for a healthy pregnancy. Ferritone offers a breakthrough liquid in a capsule formulation, eliminating metallic taste and GI irritation for easy, assured iron absorption. Calcivita's small, vanilla-flavored capsules ensure optimal calcium absorption without digestive discomfort. For fast relief from pain, Gofen's unique clear cap technology delivers results in just 15 minutes with minimal GI irritation. Mega's portfolio includes a NAT 400, the purest form of natural vitamin E, Zeman for enhanced testosterone support, and a NAT cream for flawless skin with reduced stretch marks. With a wide range of innovative products, Mega Life Sciences is committed to your health and wellness, wherever you are.
Mega, we care.
Welcome to Mega Life Sciences, established in 1980 and a public company since 2013. With a global presence in over 33 developing countries, and GMP approvals in over 50, Mega is a leader in the health industry. Mega Life Sciences has proudly served the people of Rwanda for over 9 years, supporting health and wellness in the region. Our manufacturing plants span across the globe, ensuring the highest quality products for all. At Mega, we believe in helping people stay healthy as long as they live. We are passionate about women's health and focus on developing brands with the modern woman in mind. During pregnancy, nutrition is key, but diet alone may not be enough. That's where Mega Prenatal comes in. small, easy-to-swallow capsules packed with essential micronutrients for a healthy pregnancy. Ferritone offers a breakthrough liquid in a capsule formulation, eliminating metallic taste and GI irritation for easy, assured iron absorption. Calcivita's small, vanilla-flavored capsules ensure optimal calcium absorption without digestive discomfort. For fast relief from pain, Gofen's unique clear cap technology delivers results in just 15 minutes with minimal GI irritation. Mega's portfolio includes a NAT 400, the purest form of natural vitamin E, Zeman for enhanced testosterone support, and a NAT cream for flawless skin with reduced stretch marks. With a wide range of innovative products, Mega Life Sciences is committed to your health and wellness, wherever you are.
Mega, we care.
Welcome to Mega Life Sciences, established in 1980 and a public company since 2013. With a global presence in over 33 developing countries, and GMP approvals in over 50, Mega is a leader in the health industry. Mega Life Sciences has proudly served the people of Rwanda for over 9 years, supporting health and wellness in the region. Our manufacturing plants span across the globe, ensuring the highest quality products for all. At Mega, we believe in helping people stay healthy as long as they live. We are passionate about women's health and focus on developing brands with the modern woman in mind. During pregnancy, nutrition is key, but diet alone may not be enough. That's where Mega Prenatal comes in, small, easy-to-swallow capsules packed with essential micronutrients for a healthy pregnancy. Ferritone offers a breakthrough liquid in a capsule formulation, eliminating metallic taste and GI irritation for easy, assured iron absorption. Calcivita's small, vanilla-flavored capsules ensure optimal calcium absorption without digestive discomfort. For fast relief from pain, Gofen's unique clear cap technology delivers results in just 15 minutes with minimal GI irritation. Mega's portfolio includes a NAT 400, the purest form of natural vitamin E, Zeman for enhanced testosterone support, and a NAT cream for flawless skin with reduced stretch marks. With a wide range of innovative products, Mega Life Sciences is committed to your health and wellness, wherever you are.
Mega, we care.
Welcome to Mega Life Sciences, established in 1980 and a public company since 2013. With a global presence in over 33 developing countries, and GMP approvals in over 50, Mega is a leader in the health industry. Mega Life Sciences has proudly served the people of Rwanda for over 9 years, supporting health and wellness in the region. Our manufacturing plants span across the globe, ensuring the highest quality products for all. At Mega, we believe in helping people stay healthy as long as they live. We are passionate about women's health and focus on developing brands with the modern woman in mind. During pregnancy, nutrition is key, but diet alone may not be enough. That's where Mega Prenatal comes in, small, easy-to-swallow capsules packed with essential micronutrients for a healthy pregnancy. Ferritone offers a breakthrough liquid in a capsule formulation, eliminating metallic taste and GI irritation for easy, assured iron absorption. Calcivita's small, vanilla-flavored capsules ensure optimal calcium absorption without digestive discomfort. For fast relief from pain, Gofen's unique clear cap technology delivers results in just 15 minutes with minimal GI irritation. Mega's portfolio includes a NAT 400, the purest form of natural vitamin E, Zeman for enhanced testosterone support, and a NAT cream for flawless skin with reduced stretch marks. With a wide range of innovative products, Mega Life Sciences is committed to your health and wellness, wherever you are.
Mega, we care.
Welcome to Mega Life Sciences, established in 1980 and a public company since 2013. With a global presence in over 33 developing countries, and GMP approvals in over 50, Mega is a leader in the health industry. Mega Life Sciences has proudly served the people of Rwanda for over 9 years, supporting health and wellness in the region. Our manufacturing plants span across the globe, ensuring the highest quality products for all. At Mega, we believe in helping people stay healthy as long as they live. We are passionate about women's health and focus on developing brands with the modern woman in mind. During pregnancy, nutrition is key, but diet alone may not be enough. That's where Mega Prenatal comes in. Small, easy-to-swallow capsules packed with essential micronutrients for a healthy pregnancy. Ferritone offers a breakthrough liquid in a capsule formulation, eliminating metallic taste and GI irritation for easy, assured diet
everybody.
absorption.
Can we please go back to our seats
small,
as
vanilla-flavored capsules ensure optimal calcium absorption without digestive discomfort. For fast relief from pain, Gofen's unique clear cap technology delivers results in just 15 minutes with minimal GI irritation. Mega's portfolio includes a NAT 400, the purest form of natural vitamin E, Zeman for enhanced testosterone support, and a NAT cream for flawless.
I'm sure that we were able to take in and process the discussion that we had on our first panel. Thank you so much again for the people that contributed to that panel. It's a discussion that is not going to end in this conference. Note that I want to say that it's a never-ending discussion, but it's work in progress. For the next set of sessions, allow me to introduce our next moderator. The next moderator is Dr. George Ruzigana, who is one of the faculty and senior doctors at the Faculty of Obstetrics and Gynecology at the University Teaching Hospital of Kigali. He's also a member of the executive committee of the Rwanda Society of Obstetricians and Gynecologists. He is at the same time one of the key pillars in the organizing committee that made this conference a reality. So allow me, please put your hand together as we welcome Dr. George to moderate the next session.
Yeah, thank you very much, Dr. Magnifique, for the kind introduction. And I stand before here very, very proud of the Rwanda Society of Obstetricians and Gynecologists, and as a moderator of this mid-morning session, whereby we will be joined by two distinguished colleagues, members of RSOG, who will be presenting two state-of-the-art lectures highlighting high-impact interventions at reducing morbidity and mortality. So I would like to welcome to the stage Dr. David Nirushwa, who is a senior consultant obstetrician gynecologist with more than 10 years of experience. He is currently based at University Teaching Hospital of Kigali. He is also a clinical lecturer at University of Rwanda, as well as being a Johns Hopkins Fellowship in Global Women's Health, as well as a member of RSOG. He has been in several roles throughout the past decade, and I can just kindly highlight a few of his achievements. He has been a key pillar of Rwanda Medical Association, its immediate past president, and he has been also a head of Department of Obstetrics and Gynecology from 2017 to 2023. That's a span of 6 years. So he's also a co-director at IRCAD Africa, which is a minimally invasive initiative, tailor-made also for high-impact obstetrics and gynecology interventions. So he happens to also be in several, not only local, but also global initiatives aimed at reducing mortality and morbidity for women's health. So I kindly request Dr. David The stage is yours. You're most welcome.
Thank you so much, Dr. George, for the introduction. I'm really very honored and privileged to be part of the speakers during the 10th RSOG Annual Scientific Conference. Today's my topic is going to talk about management of pregnancy in post-operative Rwandan women with rheumatic heart disease, which is really like a vulnerable and high-risk population which requires our attention as RSOG members. If we go to the next slide. Thank you so much. I want to start by acknowledging, as I do this presentation, because this is a presentation coming from a team, a multidisciplinary team, which have been put together to look at these women who have had surgery for rheumatic heart disease. So the team is made of cardiologists, cardiothoracic surgeon, obstetrician and gynecologist, registered nurse, Team Heart, and Rwanda Biomedical Center. So it is really a big team which have been put together to try to see how the improvement of these women who have had surgery can be improved. I also want to acknowledge one of the team leader, Dr. Rusingiza Emmanuel, who is a pediatrician cardiologist, but who has been involved in the management of these women since a long time, even though he's not an adult cardiologist. Then there is Team Heart Rwanda and also members of this multidisciplinary team. These are going to be my objectives, and mainly we are going to have a discussion to understand the magnitude of rheumatic heart disease, global and in Rwanda. Then we are going to look at the complexity and mainly look at why do we have to discuss about this particular population. And then we look at the impact of rheumatic heart disease on overall maternal and newborn health outcome, and then discuss about possible solutions that have been just put together up to now so that we can work together to make sure that the implementation is done. I really want to start by highlighting this story of a mother, I think, which is going to just put into the mode of what the discussion we are going to have. That mother is called Charlotte, and she has been good enough to accept to be an advocate and to share her story with everyone, healthcare providers, but also with other women and the rest of the population. She's a female cardiac patient who had had surgery by Team Heart in February 2014. She grew up in a poor family. She sometimes suffered from tonsillitis, and during those episodes, her parent advised her to drink warm water mixed with salt. And I think this is still happening in our population. They did not know that sometimes of sore throats could be a cause of rheumatic fever and subsequently of variable heart disease. In 2013, when she was pregnant with her first child, she felt bad with coughing and difficult breathing. She was no longer able to teach because she's a teacher, and she spent the whole night without sleeping due to shortness of breath. When lying down, she could not climb and even a small hill. Her life was in danger. She went to a hospital. There the doctor examined her, and they did a radiography examination, and the doctor told her that she was suffering from heart disease. They gave her medication, but continued to have severe symptoms. She returned to the hospital, and she was advised to have an abortion and to look for funding to go to China for heart surgery. She became confused and her family was not able to take her to China and did not want to have an abortion. She prepared for death. She said, I prepared for death and for my children to be orphaned. Thanks to God, Team Heart managed to offer her surgery, and now she's feeling good. There is a lot of message from here. You understand what happens, even though we are obstetrician and gynecologists and deal with this kind of patients, but there are a lot of things which happen to young girls when they get the conditions and they are treated like giving them just hot water and so. So we'll just go through, as we go through this presentation, we'll really try to see as obstetrician where we can place ourselves and make a difference. I also wanted to share this really case. Yesterday when I was in the staff meeting in our department, we had 2 cases among 10 cases which were presented, and both happened to be women with rheumatic heart disease. And again, it motivated me more that deciding to give this talk was quite important. One of the patients is 27 years old. She's having her 3rd pregnancy. She has 1 live baby, and the last baby was a stillbirth. We all know as obstetrician what all of that means. She was admitted yesterday at 9 weeks and 2 days with heart failure complicated to pulmonary edema. We were not able to know exactly what her diagnosis well. And we had to involve a multidisciplinary team, which included the cardiologist. When cardiologists came, and already this woman was in the ICU because she was intubated with a very poor Glasgow coma scale. They noticed that she was having impaired, in fact, they noticed that she was having a thickened mitral valves with mitral regurgitation and pulmonary hypertension. You understand that this is a real problem. So, and now this is a patient whom we are dealing with to see if she can really survive. We had another case of a 31 years old G4 para4004 who is known with rheumatic heart disease, and it was just last year, in 2023, that we diagnosed when she had a pregnancy of around 5 months. Now, she was admitted in a hospital. Fortunately, she got pregnant very quickly. Unfortunately, she got pregnant very quickly, but fortunately, she was followed in a hospital, 8 antenatal care consultation. She has given birth. She received the epidural, and now she has delivered vaginal and await to be discharged, and will use intrauterine device as family planning methods. So again, there are a lot of learnings. Someone is having a very high risk pregnancy, but get pregnant after just 1 year. Is again our role of obstetrician. This is an area which we need to look at. So as you can see from the 2 cases, 1 case already who is severely sick, rheumatic heart disease contribute to maternal mortality, which is really a tragedy. As you can see there, we have statistics showing that every 2 minutes we have women who die because of preventable maternal death, and most of them happen in low and middle income countries. This map is there because we are going to see how it's comparable to rheumatic heart disease. So where does rheumatic heart disease come from? As obstetrician, again, I think it is quite important that we look at it. We know this so that we can see how we can even play a role into preventing this condition. You can see just there, up there on that picture, we just have phalangitis. And this happens most of the time to children, young girls, younger boys. And most of the time they get untreated. And what happens as a complications, they develop rheumatic fever later if they were not treated. And then rheumatic fever goes to the heart and affects the valve, and they end up by having rheumatic heart disease. This is generally how it happens, and this can be prevented only if young girls were treated correctly once they develop streptococcal throat infection. This is how the diagnosis is made. Again, as obstetricians, we don't do much, but at least we ask history. We look at the clinical presentation of the woman who come to us. But when we involve a multidisciplinary team, they do ultrasound, and sometimes they can look at the valve, and they know exactly that this rheumatic heart disease, but also history is critical. Those are the complications which can happen, and the management sometimes requires surgery, and this is where we are going to go. So I've talked about prevention, and this is critical. As obstetrician, again, I think we can play a role. Most of the time when we see mothers coming to us, we need to consider them, but also we can ask the history about their children and then give kind of education. Look, if you want to avoid future challenges for their young girls when they become mothers. This problem is really very common. As you can see, around 40 million people live with rheumatic heart disease, and we lose around 300,000 yearly because of this condition. But pregnancy is the main problem because it increases even complications when it happens. The management is challenging because most of the time when medical management is not possible for rheumatic heart disease, they undergo surgery, and sometimes they get mechanical valve replacement. So with mechanical valve replacement, and you understand that they will be they will need life course anticoagulation, which we know is also associated with challenges, especially when they get pregnant. So when we looked at women, when they looked at women in Rwanda who have had surgery for rheumatic heart disease, they noticed that most of them were at an average of warfarin of 7.5 milligram as a prevention to prevent thromboembolism. And 7.5 is teratogenic. This is why I brought this particular sentence, so that for us as an obstetrician, we understand that these women who might be coming to see us, most of them are on a higher dose of warfarin. This is a global distribution, which is similar to really like a maternal mortality. And as you can see in our countries, low and middle income countries, this is where we have the highest prevalence of rheumatic heart disease patients. And this is due to most of the time to lack of prevention and the right management. So then, now what about pregnancy? That was an introduction, but how is pregnancy related to with regard to rheumatic heart disease is really like a kind of a challenge. So one of the things, like, there is a need for preconception care that we need, again, as obstetrician to focus on when we see these women. But there is also a need to understand the risk associated with pregnancy, and then we need to say, like, what kind of monitoring do we need to do? This is very critical for us once we see the woman. When we talk of preconception care, there is some particular importance. One of them, you remember when I started the presentation showing the two women. One woman who is now at 9 weeks has pulmonary hypertension already, and she has severe mitral regurgitation. So it means that if someone was able to assess this particular patient before pregnancy, would not have advised this woman to get pregnant. That's why doing like risk classification is very critical, and that's where like multidisciplinary team is very important. Then the other important aspect which we need to consider before pregnancy is management of medication. Some of these patients are on medication which are contraindicated in pregnancy or which might need to be adjusted. Again, in preconception care, this becomes particularly important. Then we need to plan monitoring. If a woman, for example, is having high risk, we know that she will need to be monitored more frequently during pregnancy compared to someone who is not having any symptoms. You remember the second case, this woman was having mild symptoms during pregnancy and even after delivery. Then we need to educate them about emergency management. So why is now pregnancy even a high risk? There are some particular risks which are associated with pregnancy, and one of them is risk of thromboembolic event. We know that as obstetrician again, that and as doctors and any other one who is in healthcare, that someone who is pregnant is more likely to develop thrombus. That's why we look at DVT and so. So we know that pregnancy is a hypoagorable steps, and if you have a woman who is having mechanical valve replacement, we really need to be careful with that because the risk is higher. Meaning that anticoagulation is necessary, but as we are going to see, warfarin sometimes is contraindicated in pregnancy, especially in the first trimester. So meaning that we need really to look at balancing the risk of thromboembolic event and the risk of bleeding, but also at the same time make sure that the baby is healthy. The baby is not going to be all right. So this is where it's related with anticoagulation challenge. However, all of us know that sometimes these women come to us maybe in the second, third trimester. I think this is a huge challenge. So meaning that all of this, being anticoagulation, being anything, all of these complications have not been taken care of. And this is why sometimes we get even a patient who is very severely sick in coma because of all of these complications having already happened. They're at risk of infection. There's at risk at cardiac complications such as heart failure. And this one, we know it better because we know the changes which happen during pregnancy, including heart rate, blood volumes, all of that, and the blood pressure going down. So with all of these changes, again, the risk of heart failure is higher, meaning that whenever we see this woman, if we can be able to identify them before pregnancy and early during pregnancy, at least we need to give them follow-up based on all of these complications that can occur to them. Then other complications include like a preterm labor, postpartum risk, which we all know. I'm very happy that we are together with Prof. Pore, anesthesiologists and others who know like how management of this patient, especially in postpartum, is very critical. Then there are also fetal risk, including growth restriction, but also congenital anomaly, especially with the medication they are taking. So what kind of special monitoring do we need to do this during pregnancy? Of course, there is preconception assessment, which is very critical to know like what kind of patient do we have? Is she eligible to getting pregnant, yes or no? Then there is regular cardiac evaluation, meaning that as obstetrician, if we see these women, we really need to consider also a multidisciplinary team, someone who can look at her heart, who can just be able like also to know that there is no other kind of big challenge. Then there is anticoagulation management, which we also have to deal with when we receive them. Vital signs are quite critical, knowing that heart failure can occur, and without monitoring that is becoming an issue. Then fetal monitoring also, including ultrasound to exclude malformation, but also other complications such as restriction and so. Then we have to manage symptoms if heart failure occur, and again, informing the woman about doing this thing is very important. Multidisciplinary care, I can't repeat it enough. It's quite needed once we see this patient. There is an aspect which I think we also sometimes tend to forget, which is psychological support. We have patients who are like on anticoagulation. Let's say that she has stopped the warfarin, she's on low molecular weight, she's injecting herself every time. So if we don't look at psychological aspect, we are really not expecting the woman to be able to follow that. So this also have to be considered as we manage these particular women. Know like what problem, what challenge are they facing mentally? Because a normal mental status is also very critical for these particular women who have had cardiac surgery. So now if you look at Rwanda, the current situation, some of the literature are showing that we have a lot of patients who are undiagnosed. Like I've seen this with this woman who just came and was diagnosed the first time when she was already in coma because they have rheumatic heart condition. And most of the patients who are operated are put on mechanical valves. This again informs us that most of them are on prolonged anticoagulations, which they need to take throughout life. So this is going to increase even more because we know that this kind of surgery are being done by visiting team, but also we know that in Rwanda, like at King Faisal, now they have started doing cardiac surgery even with the presence of cardiothoracic surgeon in Rwanda and also some other supporting team. So what have we done when we noticed that there were some challenges, especially with women coming later in pregnancy or women who are not getting the right treatment when they get pregnant? There was one research project which the team which was put together did. Mainly it was to understand like how many patients do we have and what are the challenges do they have. Then we tried to, after we noticed that most of them get pregnant, we did a second research to understand motivation, and then we started developing guidelines. So this is the first study which was published in the Journal of Cardiothoracic Surgery, and it was really showing the number of women we have who have had cardiac surgery. And again, as information and advocacy, it's just important that we know that we have this patient, and we are going to start seeing them. And I know most of OB/GYN here also have already received the patient, this kind of patient. So this study included all surgery which were done for women aged between 12 and 51. And then they received the questionnaire to answer questions such as surgical history, education provided, and then childbearing plan. So this were like the finding is, you can see on this map of Rwanda, we have this patient everywhere. You can see we have them in the east, in the north, the south, and even in Ichegari. So they are everywhere. So meaning that an OB-GYN who is in south, in west, is also likely to receive one of these women who are having a mechanical valve. So it is quite critical that we also get this information. So we had in total around 206 women who have had cardiac surgery and they had their valve replaced. This slide shows like how much it takes, and as I can also remind that the first cardiac surgery for valve replacement took place in 2006, and most of them spent like 3.8 years to have surgery, but this is a continuation. So I wanted again here to raise our awareness that we are going to see more of this patient. So interestingly, when they come for surgery, they are really, among the counseling they get is like, please do not get pregnant, because getting pregnant will increase the risk. We've seen what might happen once they happen. So they talk about family planning. And when this patient were asked, 69% of them said they remembered family planning. It doesn't mean that they don't get counseling about family planning, but whenever we educate, whenever we do the counseling, how do we make sure that this is going to stack? How do we make sure that this is going to be a continuation? Only 69% of them said to remember having had this dedication. And 54% of this patient, they reported having taken family planning. So all others never took it, regardless of the complication, the risk they had. So we also tried to look at like, who are these patients who get operated for rheumatic heart disease? As we've said, when you look at the pathophysiology, it started in the young age. This is around just children of 6, 7 years who get a streptococcal infection, and they end up by having rheumatic fever and then rheumatic heart disease. So most of them, it was noticed that around 59% of them, they get surgery before they get pregnant. So meaning that whatever as healthcare providers we do, to educate, to tell them don't get pregnant because of the complication, knowing our society, knowing our culture, these patients are more likely definitely to end up by getting pregnant at least once. So this is very critical, and these are important data that we need to understand, and they were quite interesting. And then we looked at what happened after surgery, and we noticed that after surgery, they have surgery, 39% of them end up by getting pregnant, even though they were advised not to get pregnant. So we are going to see them as doctors, obstetrician, general doctors who are here. We are going to receive this patient being pregnant, and we really have to deal with them, and you have to manage them correctly. So we noticed that, again, we wanted to look at, is their management all right? So this is about the anticoagulation. And as you can see, it is quite interesting, because there are some of the patients there, we wanted to see, like, when do they start the anticoagulation? And as you can see, there are some patients who are not even on any anticoagulation. This is represent around 4%. So they stop taking that. And you understand, we have talked about the complication, including thromboembolism, bleeding, and so. So this is really a very huge challenge. There is another around 2% who are just on aspirin. And sometimes they are put on aspirin when they come to the hospital. It's quite interesting, because this is what, again, these women were able to respond. And then there are just others who reported all of this, like 59%, they said we were on warfarin throughout the pregnancy. We did not change. We did not just take any other things, regardless of some of the complications, including complication related to warfarin, especially in the first trimester. So if you look at this slide, it shows that really there is a gap in the management, which starts from the preconception, but also even when they are pregnant. So now, what were they learning from this survey or these data? One was like to know that at risk patient get surgery, even though the interval is around 3.8 once the diagnosis is made. And we noticed that mechanical valve, there's some slide which I did not show there, but mechanical valve is like the most commonly valve replacement done. And one of the reasons is that mechanical valve can last longer compared to biological valve, which sometimes will require another surgery for the patient after some time. So this one is better when we don't have enough surgical surgeons to provide this, and also looking at the cost. But it requires that this patient be on anticoagulation, which as the OBGYN we also need to be prepared to face and deal with. The other important observation that we've had is that 54% of birth control, around 39% of these patients who have had surgery get pregnant. It means that there is no way, even though we advise against pregnancy. So some use alternative birth control and so on. And we noticed that around 59% of these patients who undergo surgery, they have never been pregnant at any time. So meaning that they are also more likely to get pregnant. Then we looked at anticoagulation. That slide, I think you've seen what is done. Most of them are not anticoagulation, or just they remain on anticoagulation, which is not the right way things should be done. So after this, when we noticed that 39% of these women get pregnant, we did a qualitative study, and then we wanted to ask them, why do you get pregnant despite having had a counseling against pregnancy because of the complication? But I think everyone can understand some of the findings were like social expectation, personal desire, inadequate patient-centered care, or lack of poor preconception care, and inadequate counseling and education. So this again shows that there is much work, but mainly social pressure, but also cultural partial pressure are quite very important. So now we had a guideline which is under development, and we almost have passed all the steps. We had cardiologists who have OBGYN who have contributed, and we have a guideline which looks like this, and I think this is where, again, in this room, we need to really say, how do we implement it? How do we use to improve the patient of the care of this patient? So the guideline have different parts, and I just highlighted some, like pregnancy risk assessment. It covers definitely what needs to be done, such as doing physical exam, looking at medication, and then there is a WHO risk classification, which shows which patient should not get pregnant. As we've said, if you say a patient with pulmonary hypertension, even when they get pregnant, they will end up by being candidate for termination of pregnancy. Then this is particularly important, and we need to educate them. We need to emphasize to not only for obstetrician, but also for any other doctor who sees this patient to say, ask the woman, when do you want to get pregnant? And I think we also need to ask this simple question before they leave our hospital. When do you want to get pregnant? Then if the woman answers, maybe it is after 1 year, it's after 3 months, it's after 4 or 5 years, then we tell them, if it is after 3 years, what are you going to do? And this is where the family planning comes. This is where we now tell them, if you really rely on any natural method or any this kind of method, you are more likely to fail. But if you ask them and they tell us really when, this is a better way to start with definitely counseling. Then the guideline also has antenatal management, where they talk about the role of antenatal care consultation. We talked about, for example, moving from warfarin, because all of them are on warfarin. Then we educate them and then tell them about moving from warfarin to low molecular weight. Then we also highlight the importance of subsequent antenatal care, which is very, very critical. We know the first antenatal care has an impact on subsequent. If they come, spend all the 6 hours, 7 hours, they come, we take vital sign, and then they go back home, they will never come back because the expectation is not that high. But when we tell them the second antenatal care, this will going to be the reason, this is what we are going to be looking at, then the third one is going to be about this, they will know that, oh, we have a plan for them. So they will more likely to come back, and this is also very important. Then we have also guidance about the ultrasound, then anticoagulation selections, where we talk about the dose and when to shift from one anticoagulation to another one. Then there is anticoagulation monitoring, which is again something critical, where we have the INR for women who are on warfarin. We know that if we are not monitoring the INR, we might be giving a dose which is putting the women to the risk of bleeding, or just giving a dose which is not enough and putting the woman to a risk of thromboembolism conditions. So without INR, then it become an issue. Again, this is clearly written into this guideline so that we can follow it and we can just be able to manage them. Even for low molecular weight, we definitely know that the anti-factor 10A is just there, and how to monitor it is clear in. Then termination of pregnancy, then delivery is also covered, which is quite very critical. So as a conclusion, I think all of us understand that rheumatic heart disease is a critical condition, and we are more likely to see women coming to us with this condition, especially with mechanical valve, because surgery are being done. You've seen that the numbers are high, and it is very important that we consider multidisciplinary, we consider looking at the anticoagulation because it is not well managed, but also preconception counseling is very critical so that these women feel happy and feel ready to come to us, because otherwise they have this tendency that before having surgery we were told not to get pregnant, and then we see them when it is too late. So these were the resources I used, and I thank you so much for the attention.
So thank you so much, Dr. David, for the informative presentation. I would like to first ask you to just sit on the podium for a few question and answer sessions. But before the question and answer session, I would like to tell the audience to wait for a second presenter so that all the questions can be gathered and asked at the same time. So without further ado, I would like to welcome our second presenter, who is none other than one of our senior coach, mentor, and a founder member of RSOG. This is Professor Stephen Rulisa, who is a professor of obstetrics and gynecology at the University of Rwanda, with over 20 years experience working in the field of obstetrics and gynecology. He is also maternal health research and academia with over 120 peer-reviewed publications. So the list goes on, and I would like to invite Professor Rulisa for a presentation, and he will be presenting on high-impact interventions to accelerate maternal mortality and mobility. The floor is yours, Professor.
Thank you. Thank you very much, George, for that introduction. Distinguished guests, dear colleagues, ladies and gentlemen, good morning or afternoon. Good afternoon. So I will take you through, I hope I will make time, on high impact interventions. That is interventions or innovations at the same, to accelerate maternal mortality reduction in general. Let me start with this interesting slide, the Start Global, and then I will narrow down to our local context. When we talk about maternal mortality and child mortality in general, 80% of maternal death lies only in 25 countries. So, and when you do this, most of these countries are in sub-Saharan Africa, with the exception of 2 countries, India and Pakistan, in Southeast Asia. We are carrying 80% of the global burden of maternal mortality in general. If you take these numbers and you take out Nigeria and DRC, maternal mortality reduces to 30% global. So 2 countries carries 65% of this burden. So this is where we stand. We stratify these numbers in terms of populations, rates, but we also stratify in numbers so that you can have an idea. Let's talk about an approach, a proactive approach to focus on product uptake and introduction of these innovations that we can use to accelerate maternal mortality reduction. When you see the global trend, you can see that since the year 2000, I don't know what happened in the year 2000, everyone was excited and we started seeing global maternal mortality reduction going down tremendously all over the world. But by the year 2016, stagnation started. The rate of reduction was above 30%, and now we are almost 3% since 2016, with the exception of very few countries. Despite that, there has been lots of innovations that can reduce maternal mortality. The question is, are we using them? Why did we stagnate at a certain point? There were interventions that we used that worked really tremendously, made a huge impact. At a certain point, they couldn't work, but people stopped there, kept forcing to use what worked before, assuming it will keep working the same after 10 years. And it didn't work. And we saw stagnation in general. There are several innovations, around 7 of them, that impact maternal mortality reduction tremendously, that we can talk about. 7 of them are already available and proven, with no doubt, to reduce maternal mortality globally. And there's also one interesting study that was done by a group in Copenhagen that shows that $1 invested in maternal mortality interventions saves almost $83. This is one of the best investments you can do globally. The question is, why don't we use them now? Let's see what is happening globally, and then I will narrow back to our region and to my country here. Maternal mortality rate, global reduction from 250 now stands at around 152. Let's go to number of stillbirths, went down from almost 5 million to 1.8. Number of children and newborn, the same reduction. But are we meeting sustainable development goals with these reductions? I don't think we can if we keep doing business as usual. The question is, what kills women? Science is available, that everyone is common knowledge. We know what kills women. And if you ask, even my students, when you ask them, what's the commonest causes of mortality, they will say, 1, 2, 3, 4, 5, and they say them. And you ask them what can treat them, and they will tell you, as a sake of exam. The question is, why do women still die? I don't need to tell you what kills women, you know it, postpartum hemorrhage, infection, nutrition related, undernutrition, keep overnutrition for now, is not applicable to your setting, eclampsia, and many others. But if you eliminate the first 3, then you're done. And if you ask how do we fix PPH, everyone would top of your fingertips. So why do we still have women die? That's the question. And I want to tell you, when you list down all medicines we use in general and put a price tag on top, the cheapest medicines are the ones we use in maternal health. So the cost is actually not that of the reasons why women die. There's still another underlying problem somewhere. Let's go now to the real problem of why women die. The question is that the goal is to intervene as early as possible to prevent poor maternal and neonatal outcome. We need to address the underlying biological vulnerability rather than a single syndrome. Let me give you an example of PPH, which kills women. There's now data that shows over 80% of women who die of PPH, they had anemia during pregnancy before childbirth. It's not just breeding, they had the predisposing conditions before that was not fixed. By the time they deliver the baby, they're already at high risk. So if we didn't intervene early in life and address these vulnerabilities, we're still going to see maternal mortality. Number 2 is to intervene as early as possible in life course with a preventive approach. Number 3 is to improve on-the-ground data and produce development in the pipeline. We use our local data. Why don't we use our data? I liked, I think it's yesterday when I was talking to Prof. Kihara about maternal mortality in Kenya. The question is, we have a global data, but if you go in silos, some of the counties have one of the highest in the world, but when you average them, you think is a little bit lower. But why do we keep these silos up? Why can't we address the vulnerabilities? And this happens all over. Number 3 is proactive address these innovations. Now let's talk about these biologies. For example, during pregnancy and childbirth, and then after for infant mortality. During pregnancy, you need to address anemia. Is one of the biggest killer, is one of the leading cause of PPH that we see. So we need to address this biology that happens before, and we know it. Number 2 is undernutrition, maternal underweight, inadequate gestational weight gain, and micronutrient deficiencies. These are the biggest drivers of mortality globally. And if we don't address them, before childbirth, when we see a woman die and we attribute it to delivery, we will keep seeing women die because these conditions have existed before. And then preeclampsia, why can't we detect? Do we know these women who are at risk of eclampsia by the time they come to deliver or are in their pregnancies? This is what we need to address. Perinatal period, maternal postpartum hemorrhage, postpartum anemia, preeclampsia, neonatal stillbirth, preterm, and so on. For infants, underweight, wasting, stunting, and so on. In this country, we're now struggling with stunting as the biggest problem. But we see children stunted in the street and say, hey, maybe the problem is the mother and the food. The thing started in utero. If you didn't prevent it during pregnancy or even preconception of the mother, you're going to keep struggling with this. And we know this. Science is available and shows it. So this is where we need to act. So let's see, leveraging the power of science and innovation. I put this because I'm talking to scientists. And you can break down this knowledge to anyone, but you as a scientist, why don't we leverage the power of science? We have evidence, we have high impact, cost-effective products that can address these underlying biological challenges we talked about. For example, creating bundles that package together highly effective and low-cost products that address the major risk. I just bundled them into pregnancy, delivery, and then postpartum. In pregnancy, what do we need during pregnancy? We need to diagnose anemia as early as possible. We need to prevent anemia, prevent adverse birth outcomes. We need to identify women at risk as early as possible. We don't want to wait when complications have shown up. Another one is gestation age dating and to manage moderate to severe anemia as early as possible, and then act early in life. And we have bundles that can fix these problems. For example, health pregnancy bundle, administration of micronutrient supplementation is very key. I will talk about it later. There's a huge study that was done and in Kenya, India, Nigeria, and many other countries that shows, and there's another global data that worked on this. We still give iron and ferrous, but these women are lacking many other micronutrients. Why don't you give calcium? Why don't you give zinc? And you can put them in one tablet as you give iron. And these micronutrients are the predisposing factors to these conditions we found. Maternal azithromycin. This is another big elephant. Infection kills women globally. And there's a huge evidence that maternal azithromycin prevents death above 65% in general. And it stays in blood circulation for the next 30 days, preventing neonatal mortality when women are breastfeeding. Why don't we do it? It's even cheaper than most of the antibiotics we use, but many policies still use medications that are not as highly effective as azithromycin, and is available on the market. In this country, we have maternal azithromycin. We have azithromycin listed only for pneumonia in children. Why don't we use it for maternal? And these are doctors, you can prescribe it, you can put it on protocol, and we can change things. Number 2 is delivery. I will talk about AI-enabled ultrasound. If we need to change the way we do business, we need to embrace technology. We need to adapt to AI-enabled ultrasound. Anyone can do it. Anyone can use it, even a cleaner. Well, that's a bit of extreme. But a very minimal healthcare worker and nurse can use this ultrasound and get as the same result. I don't want to say better than you, of course, but it can give you a very good result. And then you know, early in life, every woman who comes, we just 3 times, tan, 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 and then tan, tan, it gives you all the results. It is available, it is cheap, and we can use it. Number 2 is delivery. During delivery, prevent maternal sepsis, prevent respiratory distress syndrome for babies, monitor risks, diagnose and treat postpartum hemorrhage. We have available bundles of interventions that we have, for example, IV iron. I will talk about it later, that over 65% of women who start without anemia at 14 weeks of gestation, by the time you go to 34 weeks of gestation, they have high levels of anemia. But you screen them once and you assume, well, this one is anemia-free. By the time they deliver, these women have anemia and they can have a risk of PPH that you can't easily control. And these interventions are there. If you give IV iron, you can't give ferrous to someone who is already bleeding. It's too late. You can't fix the problem. IV iron has been proven. Data is available globally that is highly efficacious to use IV iron. Last is management of preterm and low birth weight, manage respiratory distress syndrome, and treat possible severe bacterial infection. The bundle that is available on the market is antenatal corticosteroids, which are highly efficacious. Do we have them on our treatment protocols in CPAPs, probiotics? Probiotic supplementation, I think I won't talk about it later, but is one of the game changers for neonatal and infant mortality. Supplementation is affordable, but is not most of essential medicines in most countries. So, if we need to change the trend of maternal neonatal mortality, we need to scale up these interventions. If we need to move from that side to this side, you need at least to apply them at the level of 60%. Only 60%. If you do that, PPH management, maternal azithromycin, IV iron, AI-enabled ultrasound, you change up to 65%. And most of our sub-Saharan African countries can achieve SDGs if we only use these interventions. They are available. There is no question about their efficacy, and they are affordable. Let's now deep into progress on this outcome. There is sub-Saharan Africa, Southeast Asia, and global, so that you know where we stand as a sub-Saharan Africa. You can see where we are as sub-Saharan Africa. We are on top, lagging behind on the rest of the world. And you can see here, child mortality is the same. Let me go to this. This is a study that was done beyond high overall anemia and iron deficient anemia, but then global prevalence of micronutrient deficiency is elevated among women of reproductive age. It's not only anemia that is lacking. See what is here. These women lack vitamin A, lack folate, vitamin B12, vitamin D, iodine, zinc, anemia. Why do we keep giving folate? We have one tablet of micronutrients that has all this. Instead of giving only folate, give one tablet of micronutrient and change the game. This is another evidence of multiple micronutrients. It's more efficacious than iron ferrous. These are percentage of reduction in selected birth outcomes. Stillbirth, you reduce 21% of stillbirth by giving micronutrients. Infant mortality, 29%. Low birth weight, 19%. Preterm birth, 16% reduction. Only by giving these tablets of micronutrients. This is the study I was talking about that was done globally. Longitudinal data highlighted incidence. Women who were 13% anemic, by the time they get at 36 weeks, they are 36% of anemic. So anemia goes with gestational age. So we need to act. When they are 51% with iron deficiency, by the time they are 32, 79% of them are iron deficient anemia. And this can't be fixed by ferrous. It can only be fixed by IV iron supplementation. So these are the interventions I'm talking about. Micronutrients plus calcium, they are available in one tablet, and you can give them daily supplementation to replace iron supplement. AI-enabled ultrasound, this is a point-of-care ultrasound to guide location, frequency, and contact of ANC visit to improve stratification. You can put it at any point of contact in health center. IV iron, a one-time 15 minutes infusion of 1,000 microgram changes the game. Maternal azithromycin given as a single 2-gram dose to mothers in labor, also during pregnancy for STI prevention. And then PPH detection bundle to improve blood loss. I will talk about it later. Let me give you, I think I'm running out of time. Let me give you data for Rwanda. These are the trends. Where do we stand as a country compared to the region where we are? The other side is Sub-Saharan Africa, maternal mortality, and we tried to model this data to see, can we achieve SDGs by 2030? We are going only to be at 259, and the SDG is 70. Rwanda has managed to embrace some of these technologies, including the other invisible that we'll talk about, including HRH and so on, and the governance, which is not a measurable indicator that we have, but has made a huge impact. Governance is a huge impact. We are going to attain SDG if we keep what we are doing and by 2029. And this is also on child mortality. The target is 14. Is easy to achieve. Child mortality has been going down faster than maternal mortality. This is where we are compared to Sub-Saharan Africa. When we started in 1990 or even after, Rwanda was almost one of the highest, higher than the average of Sub-Saharan Africa, but it made a very important strides, and we're moving down now much, much lower or higher than Sub-Saharan Africa. We modeled this data of MNCH innovation, put Rwanda in context with East African countries to have an idea of where do we stand compared to our neighbors. Most of the countries are above 300, on average between 400 and 500 maternal mortality, and we are now at around 105. This is when you put Rwanda compared to the countries which are on track to achieve SDG in Africa, that is Egypt, South Africa, and Tunisia, together with Rwanda. When you model their current data, these are the only countries scheduled to achieve SDG by 2030. And these are compared to other data, and because of my boss, who is here, I had to model data for Kenya. It's one of our neighbors, it's one of our leading countries in East Africa. Where do we stand? Something went wrong somewhere. It doesn't show on any data we model currently that Kenya can achieve SDG now, stand at 400 something. And these are our neighbors. Now we talk about collaboration in the future. If we need to make a difference, we can't stay as a silo. We need collaboration. We need to work together as a region. These are a snapshot of Rwanda, what we need to accelerate the plan. These are our current maternal mortality. Maternal mortality, the target of SDG is 70. We now stand at 105, and we are on track to achieve maternal mortality. So the current maternal mortality in Rwanda is now 105. Neonatal mortality at SDG says 12, we are at 28, and modeling data shows that we're there together with the under 5 mortality. What do we need to do? Fund research on cause of premature death, preterm death. We need to fund research on maternal mortality, and we need to develop adequate guidelines to include these innovations. We know them, they are available. We need to work on the guidelines for us to keep on track. We need also to strengthen and scale up patient voice programs to voice engagement. Patients need to know what they ask for. What else do we need? These are maternal health snapshots for Rwanda. I think I'm running out of time, but we can discuss them. I think it's better I leave some of them so that I can leave questions for you. Give me 1 minute to talk about this bundle, the use of DRAPE for PPH. We did a big study in Nigeria, and we found you ask any doctor, what is PPH? Everyone will say 100 or 500 cc. But you say, but how do you know 500? Yeah, of course, women has breathed 500. But how? Tell me. If you pour blood on a sheet or on a mattress, how much is 500? 80% of them miss the point. By the time they call it PPH, it's already too late. So you can't do this now. This drape is a very simple technology. It's like a drape on a sheet. Every drop of blood will be corrected and will be measured, and you detect PPH much earlier. Our technique we use now of looking, breathing, and you look at the bed sheet or something and you say, yeah, well, I think it's too much. I think it's PPH. It's already too late. And there is a huge data on that we can use this drape, and we reduce 60%. Percent of severe outcome was reduced by 60% when we use drape compared to using the other one. AI ultrasound used by any nurse in a health facility. If you are at risk detected in the first trimester, you jump the queue and you get referred by the nurse. It can detect anything at that time, and it can make a difference. It's a game changer. My last slide is on this. There was a huge study sampled in most of sub-Saharan Africa and Asia on medicines that we use. Where do we stand? And we found that ergometrin, only 75% of this medicine had nothing to do. Wearing hubugari. Like nothing, no active ingredient, no heat stability. It's like eating kaunga. Nothing at all, 75%. Oxytocin, 39% of the medication not effective, and is on the tray being used. Misoprostol, 38%. Cefazorin, penicillin G, 13%, and so on. Where do you procure your medicines in maternal health? Where do you store them? How do you use them? Matters. It's a huge factor. Where do you buy your? I'm not going to name the countries that manufacture these drugs, flood our markets, but you've got to be careful. And where you buy these medicines, at the same price, you can get a proven medicines for this. So I think I will stop here. Even this thing has jumped. I think they are tired of me. Thank you very much.
Another hand of applause for Professor Rulisa. And also thank you for our two presenters. And I would like to welcome you to the podium. And because in the interest of time, I would welcome not more than 2 questions from our audience so that for our 2 speakers. The floor is yours. Prof. Ole.
Thank you very much. And I know David was expecting a question from me. When we talk about maternal mortality, that's where we meet. when it is about philosophy and whatever, you can eat it yourself in your corner. But when the mother is dying, anesthesia, critical care is there. It's really unfortunate that when you define your skilled attendant at birth, you never put anesthesia. We all attend together, high-risk birth. So if possible, Figo is here. Skilled attendant at birth in hospital, anesthesia should be put on. Because we are together. So coming to that, David, a word in French, je suis resté sur ma soif. Because we saw the trend of those mothers with cardiovascular disease, post-cardiac surgery, the way we took care of them, but the study just limited when before birth. We didn't see data. How did they deliver? How many delivered normally? Because with a metal, how many delivered normally? How many underwent C-section? And which anesthesia? That's where peridurals become really one of the recommendations. Pre-C-section, it gives more chance to deliver normally when you are under peridural. And even it comes to transform into C-section, it's faster and saves life. So I think if there is a way we can continue this study and see all those ladies when they come to deliver, how much chance are they offered to escape death by giving them a peridural. So among the intervention again, I think all those interventions are good, but there is an intervention about peripartum management and the resuscitation. Scale up the level of our, can say, critical care providers in Rwanda. The whole Rwanda has only 3 intensivists. They are not even specialized in obstetric intensive care, which is another specialty. The whole Rwanda has 0 obstetric anesthesiologists, 0 obstetric anesthesiologists. Because we take anesthesia just as everyone can be called and say, oh, take care. There is specialty of obstetric anesthesia. So my intervention is just to tell you, please let us be realistic. There is things we can say, okay, anemia, they found that if someone going to PPH, if he has anemia already, it's too late. But how much do we invest into peripartum resuscitation and intervention by providing good training to anesthesia providers, to intensivists, and also helping those non-physician anesthetists who have been trained just on ground, or can say 3 years post-secondary school. Are they well enough to work with you who are undergoing subspecialty in obstetrics, to work with people who are still low, to save your patient? Please, as we are thinking of elevating the pyramid of obstetric, please think about that skilled attendant at birth called anesthesiologist and critical care. Thank you very much.
Yeah, thank you, Professor Pole, for the multidisciplinary approach. And I would also welcome a question from our president for our 2 speakers.
Actually, it's not even a question. It's something that has disturbed me for a long time, and I'm looking for a solution pathway. How many of us look at reproductive planning and plan with the women? Whether it's the cardiac patient, the hypertensive patient, or the woman who wants to have her reproductive career. This brings up the concept of preconceptual care and the interbirthing interval. I really have a problem in the sense we have not put emphasis on preconception. So we're not even doing upstream risk assessment of conditions that exist, prophylaxis we need to put in place, and including maternal vaccinations. So to me, by the time you're getting PPH, I call it a knee jerk. Things happened long ago. So I'm challenging all of us. Can we seriously put more concerted effort with preconception care and reproductive planning with the women we see?
Yeah, thank you for the good questions. And I would also pass the floor to our two speakers, Dr. David and also Prof. Rulisa, to give us some insights from the questions that have been asked. The floor is yours, Dr. David.
Yeah, thank you, Prof, and thank you to our FIGO president for really like the great comment which came from these two presentations I've made. I want to make a comment related to what Prof. Pori said about anesthesiologist being part of this. And even when I was doing my presentation, one of the areas of emphasis I wanted to do, it was about multidisciplinary. Multidisciplinary approach, which requires that as doctors, we do not feel like whenever a patient comes to us, we can do everything. The best thing the patient expects from us is like to be able to do what we are able to do, but also to ask them questions and also to give them guidance and to let them know that we can work in a team. So that is something that probably is lacking. And this is one of the main reasons when we did that survey, you could see some patients were just put like on aspirin, or even not on anticoagulation, or even like on warfarin the whole pregnancy, even when they come to the hospital. So it shows really like multidisciplinary approach is something we need to embrace. And I think no question about anesthesiologists being part of obstetric. Now, as we said, you remember when I was presenting the two patients we are having in the hospital, one of them who is very all right now, who I think she might be discharged by the time now, she was on epidural anesthesia, meaning that we had anesthesiology team in the Reba ward working with us. However, one of the big challenge, and our president also talked about it, is about really like, what do we tell women? How do we anticipate? Because I have a feeling that as obstetrician and with regard to maternal health, anticipation is the most important thing. Even when a woman delivers, before she leaves the hospital, we need to start planning about the next pregnancy. We need to ask her, like, when do you want to get pregnant? And we need to assist, we need to let her know about the complication which might occur. So this is particularly important because, as you've seen, like you had one woman who delivered just in 2023, had the cardiac condition, and in 2024 again delivered. So this shows really a huge gap with regard to preconception and care. And this is an area which requires not only as obstetrician, but also other healthcare providers. You see, this patient with cardiac conditions, they go to most of the time internal medicine, to the general doctor. But no one really, most of the time we forget to ask, like, when do you want to get pregnant? If we have someone with cardiac condition, with mental health condition, who is any medication which are not eligible, which need to be changed when someone gets pregnant? And this is where everyone we need to be together, including pediatricians. Most of the time who see mothers coming for vaccination, when the mother bring their babies for vaccination. So at this point, they could even consider like what would happen, how do they prevent the next pregnancy? They have this baby sometime with stunting and so, but again, the pediatrician have responsibility. So showing that with what Prof. Ann said, we really need everyone involved, and what we need mainly is to have a guideline which include all type of healthcare providers, because we don't have that. In many countries, there is no guideline for preconception and interpregnancy interval and their consequences, and who should be involved. Thank you so much.
Yeah, Prof. Rulisa, you have 1 minute.
I always have the least minute. Someone sent me an article this morning that says you can't achieve something you didn't expect. So I agree with what Prof. Kihara says. If we don't anticipate, and in my talk I said, if you can't address the challenges we have now, more than 90% of them started much earlier in life. So preconception, of course, no question about it.
Amazing. Thank you so much. You may go back to your seats. Thank you very much. That was great. Okay, so just before the next person comes, I'd like to kindly ask the guest speakers, as we've been late already, we would like you guys to just mind the time, mind how many minutes you have, and please respect the time and respect everyone here. Thank you. So I'll be introducing Dan Butare, an obstetrician and gynecologist from Gahini Hospital. Thank you. Apologies. Instead of Dan Butare, we will be having Dr. Basonge Emi. Thank you. Welcome into to the stage, please.
Thank you very much. For the interest of time, by the time I complete someone's bio, you're here. Thank you. So, I think IT also disturbs our time. So, next speaker will be Dr. Antoine Osongo. He's a physician researcher who graduated from University of Kinshasa with expertise in minimally invasive surgery and is a specialist in obstetrics and gynecology. More details will follow. Please welcome Dr. Osongo Antoine. Thank you.
Good afternoon, everybody. On behalf of Dr. Antoine Musongo, my name is Excellent Rugenda. I'm a researcher at MEDREC, Medical Research Cycle. In this moment, before I start, let's say you're going to apologize my English because I'm a French speaker. I hope I'm going to be to do my best to communicate clearly, and I'll appreciate your understanding. Thank you so much. Yes, that is.
Oui.
Thank you. Aujourd'hui, nous allons parler de l'induction du travail. L'induction du travail.
Today, we are going to say about induction of labor.
The method. Excusez-moi, je peux même parler en anglais, ce n'est pas grave. Okay. I'm going even to talk in English because to translate it every time what I'm going to read, it's really hard for me. The induction of labor, the indication, method, and outcome in the lab research settings, a cross-sectional study. Before I start, let's give a thanks to my collaborator, who are there. Together we've made these abstracts and other more. This is what our agenda. This is our agenda style. This is the point that we're going to have in the abstract. The first we're going to have an introduction, the method and the result. the discussion, and at the end we're going to conclude. This is our resumes look like. If I could get a little time to present this works, this study, maybe about 2 minutes, this is what I could read for you. But I have more than 2 minutes. Reason why we're going to talk about those elements, those points. The induction of labor is a common obstetric procedure that indicates when a vital benefit to the mother or fetus outweigh the benefit of continuing the pregnancy. Most often, induction of labor is performed on an immature cervix. The use of prostaglandin is essential in the case of unfavorable cervix. To fulfill our research, these are questions we put. The first, what are the indication methods and determining factor of the outcome of induction of labor? The second, what are the determinants of the outcome of induction? The third, what are the main indications for induction of labor? The following, what are the most used methods to induce labor? And what are the complications related to labor induction? The method we use, we conduct a descriptive and analytical study of a period of 1 year from May 22, the year 2023 to 22nd April 2024. It concerns all pregnant women received at the maternity yard for labor induction and carrying a pregnancy of more than 24 weeks of amenorrhea. The results we found in our research, the age of pregnancy in induction was dominated by pregnancies from 37 to 41 amenorrhea weeks and 6 days. And that means a percentage of 18%. Oh, sorry. There was something, maybe I was jumped. I could first begin by here. This study shows a prevalence of 7% of induction of labor compared to the total number of deliveries. The case we chose was concerned 1,677 vaginal delivery and cesarean sections. In those cases, only 7% consent in induction of labor. The major of pregnancy women were between 19 and 29 years old. 77 had at least 4 prenatal consultation with an average of 4.1, more or less 1.2. by continuing with our result, about 94 of pregnancy women were carrying a pregnancy with cephalic presentation. 89.7 had a bishop less than 6 before induction. It is an average of 3. The first indication for induction is prenatal rupture of the membrane due to 24%, followed by elective induction due to 23%. Misoprostol, oxytocin, and artificial rupture of the membrane bag of the water bag, please, is the most used induction treatment regimen at 67.8%. The age of pregnancy at induction was dominated by the pregnancy from 37 to 41 amenorrhea weeks and 6 days. 75% induction result in delivery at the end of the first induction. 22% were re-induced, and 32% were transferred to neonatology. Vaginal delivery at the 97% significance level. There is also, we have to mention that there is also a significant association between the outcome in induction and the history of vaginal delivery. This is what we found. The probability of successful induction of labor is higher at 84% in a woman who has already given birth vaginally given birth vaginally. And also we found that that probability was low in a woman who has already given birth by cesarean section. The probability also was successful induction of lab. The probability of successful induction of labor is very high also in a woman who has performed prenatal consultation for over 4 consultations. We found also that the successful induction was high, and we can just appreciate the value there at 75%. We also found that the neonatal death due to induction represent only 2.3%, and only 1 case was recorded. It's really successful. According to the discussion and observation, there was some limitation of this study. This study focused on induced case and did not consider comparing them with control group in order to compare outcome. We had difficulty analyzing the quality of labor in order to identify its impact or maternal fetal outcome, and this identify its impact as a confounding factor. Limitation related to the type of study and its biases. Problem of generation of the result, because we have a non-probabilistic convenience sampling. The lack of sincerity of some health personnel which would give an information bias. Thank you. And this is the conclusion.
Thank you very much.
We are reaching the end. Thank you so much. Thank you very much.
Yeah, I think you can join the podium as they will ask you questions after.
Thank you.
Thank you very much. So, next of our presenter will be Dr. Dawit Wolkukasa. You all know him. He's our very renowned professor. He's a lecturer who has trained one of the fellows you saw yesterday. So he's talking about determining the rate of clearance of HPV infection and factors affecting the rate of HPV clearance among women who were treated for precancerous lesions of the cervix. Please give a round of applause as he gives us this crucial presentation. You're most welcome, sir.
Okay, good morning or good afternoon. Okay, so the abstract that I'm going to be presenting on is about HPV clearance on women who have received treatment for precancerous lesions of the cervix, and also determining what the factors that contributed to the clearance of HPV infection after treatment with thermal ablation and LEAP treatment. So as you know, cervical cancer is one of the common cancer affecting particularly women in the developing nations, and the burden of the disease is really high in countries where we don't have vaccination, regular cervical cancer screening. And when we see the local context, yearly we're having more than 1,200 women diagnosed with cervical cancer, majority of them being at an advanced stage. So WHO put criteria or strategy to eliminate cervical cancer, and countries have agreed to work on vaccination, screening and treatment with 90-70-90 plan. And for this plan, 90% of girls need to be vaccinated, 70% of women need to be eligible, women need to be screened, and 90% of them who are having precancerous lesion will be treated for precancerous lesion, and those with malignancy will be treated with surgery or chemoradiation. So the objective of this study is to determine the rate of HPV clearance among women who have been treated for precancerous lesions of the cervix, and also to determine the factors that determines the rate of clearance. So the study was conducted in Gicumbi district. So in Gicumbi district, there was a mass campaign primarily focused on primary HPV DNA testing. This is health professional assisted self-sampling with HPV. And around 20,000 women have been screened. Of those, 500 of them were treated with LEAP and thermal ablation, and 20 were identified to have invasive cancer. And of those 500 who have been treated with suspicion of precancerous lesion of the cervix, they were appointed a year after for follow-up. And this study focused on the HPV clearance 1 year after having a treatment for precancerous lesion. So this was the algorithm or the treatment plan. So a woman will have HPV DNA at the time of screening. If she's positive, there will be VIA at point of care. Then when VIA is positive, there is going to be thermal ablation or LEAP, depending on the degree of precancerous lesion diagnosed with the VIA. And 1 year post-treatment, they come for follow-up, and this is where we did the HPV clearance test. So there are many health facilities that contributed to participated in the study, and basic demographic data and HPV DNA testing for follow-up plus VIA was done after patient come for a follow-up visit. So 202 women were enrolled in this study, and the median age of the participants were 40, and the mean parity was 3.9 or nearly 4. And majority of the women received thermal ablation. Only few patients received lip treatment, and there was a significant number of women who were on follow-up having HIV infection, and obviously those patients with HIV will come for screening and treatment. That's why the percentage is really high. This doesn't represent the national HIV positivity rate. So this bar graph shows the initial HPV infection for those women who were treated with for precancerous lesion. And as you can see, majority of the women have high-risk HPV other than 16 and 18. And this is the other HPV's high-risk subtype that are known. Only few have 18 and also 16. So the HPV clearance rate 1 year after treatment with LEAP and with thermal ablation is 68%. And we did multivariate analysis for the demographic data, the type of HPV, the HIV status, parity, and so on. And the one with significant association for determining the clearance rate was the initial HPV infection. And those patients who have HPV 16 and 18 at initial presentation during treatment had a higher chance of persistence of the infection. And as you can see, particularly patients, this also is supported by scientific evidences, like HPV 16 and 18 are associated with persistence of the infection, development of precancer, and finally development of cervical cancer. One very interesting finding that we found is even though the clearance rate for HPV infection is 68%, the VIA result for those patients that come for follow-up, if we use VIA as a proxy for cure of this patient, the clearance or the cure rate is close to 85%. So this will raise a question. So at this patient, as we know, the positive predictive value for HPV is really low. So are this patient with HPV positivity after treatment, 1 year after treatment, are really having a reinfection, or are they having the persistence of the infection, or we're having an abnormality or unreliability of the VIA result? So this is one area of further study that we can consider. So in conclusion, we have HPV result clearance rate of 68% after treatment with thermal ablation and LEAP, and HPV subtype 16 and 18 were one predictor for persistence of the infection. And we need to do further study in this regards about what persistence of the HPV infection or clearance of 68% really means in these patients who have been already treated. Thank you so much.
Fantastic. So he has managed time very well. Even beating precancerous or cancer lesion is a possibility. So let's welcome the last speaker for this. That is Akilimali Aima, who is talking about investigation of incidence and clinical characteristics of preeclampsia and eclampsia in a woman from women in tertiary hospitals. Please, let's welcome him with a round of applause. The floor is yours.
Hello everyone, I'm Aimar Akilimali, MD from ZR Congo, and I work at Medical Research Cycle. I would like to apologize for my English as I'm French speaker, but I will try to do my best. My topic is about Okay. My topic is about the investigation.
Okay, let's proceed with some questions, and we'll have this presentation in a few minutes. Does anyone have some questions for the panelists here? Yes?
Thank you very much. I have two questions. I'll start with the oncologist. We talk about HPV clearance in women. What is the role of vaccination in boys and men? Number two, knowing that now you have the BioNTech coming to Rwanda, which vaccine would you recommend? Because I saw you had 16, 18, but the majority were the other variants. Should we then be thinking of the quadrivalent or the nanovalent? Congo, thank you very much for the induction of labor. There's a whole push now. Does induction of labor predispose one to PPH? And maybe in your study, a sub-analysis of the gestation, whether it was preterm, term, post-term, or post-dates, may have given us a little bit more insights. I don't know whether you have something to say about that.
Okay, thank you for the interesting questions. With regard to vaccinating boys, HPV infection, as we know, it's transmitted sexually, and if resources are lost, the recommendation is to vaccinate both boys and girls. And this will definitely reduce the burden of precancerous lesions and also avoid diseases in boys like condyloma, and even though it is rare, the development of penile cancer in the future. The vaccine, the most common type of HPV associated with precancer and cancer is still 16 and 18 globally, but there are data that show in some countries there is another subtypes like 56. Variants 56 being very common. So the recommendation now, so far we had bivalent, quadrivalent, and since recently we're having a nanovalent vaccine, which would cover 9 types of high-risk HPV, and if resources are lost, this would be the best vaccine that we can give to our girls. Yeah, thank you.
Thank you for the question. To give a good response, I think it will be better to say it in French. C'est vrai qu'il y a eu tellement d'avancées dans le traitement de l'injection due au travail. Yes, it's good. De l'injection du travail.
induction of labor.
Et il est aussi important de faire un traitement, disons, personnel, c'est-à-dire connaître l'état du patient, connaître tout ce qu'il a comme antécédent.
It's very important to know the patient and to identify the past medical history, like antecedents.
Ce qui peut aussi conduire au bon traitement quand l'induction due au travail est engagée, en fait, et est indiquée.
Take measures during induction, and then you anticipate the problems.
Mais il y a eu certainement quelques cas peut-être enregistrés, mais que nous n'avons pas pu identifier dans notre travail.
In their area, there are some cases they didn't identify with those problems because they don't have records of some cases.
Mais il faudra bien quand même que le médecin soit beaucoup plus rigoureux et prenne en charge le cas.
The medical doctor is engaged in the better management, in good management of the patient.
Pour éviter à ce que de tels incidents se produisent.
To avoid some problems or complications during labor. Thank you.
Merci beaucoup.
Merci beaucoup pour la question. Je vais ajouter à sa réponse. Je suis aussi investigateur dans leur travail, mais concernant la question pour les indications de l'accouchement, les femmes avec rupture utérine, vraiment, bon, chez eux, on n'avait pas procédé à l'induction. Mais les autres, ça va. On a essayé d'éviter les hémorragies postpartum à cause de la rupture prématurée de la membrane. Ok, merci.
He says in their country, the management or prevention of PPH, they follow it and anticipate. Because most of them, when there is a rupture of membrane, mostly the patient develop a PPH, postpartum hemorrhage. Thank you.
Well, if there are no more questions, we can give a round of applause to our presenters. We are sorry for the last person. The MC.
Thank you very much. You may take your seats. Let's give them another round of applause. We want to respect and honor you from traveling from Congo to present. And with the language barrier, it's not easy at all. So we respect you and honor you. Okay. Thank you guys for waiting and being patient with us. We'd love to have lunch, right? You want to eat, so please let's go and have lunch. And I'm just going to allow Dr. Hawimana to speak for a few minutes just before we have our lunch. Thank you.
Thank you very much, the MC. We would like to call upon the next three presenters who will try their best they can to respect time, otherwise we will have all the night here. So please, may I call Dr. Dawud to come and present her research project.
Very much. I will be discussing about a case presentation. My presentation is a bit different. the previous presentation because it is just a clinical part. I am going to share you a case that was managed in my setting, in my hospital in Ethiopia. So this is a lithopedion, a stone child for 25 years in a woman's abdomen, opening. So let's come to the outline of the presentation will be to, I will have my objectives, case presentation. I will discuss some of the pointers from this case presentation, and finally I will present my reference. So since the case is a very rare one, I would like to touch some of the pointers regarding defining the condition, to discuss about some clinical presentations, the diagnosis and the treatment of this condition. So the case was a 50-year-old woman. She was gravida 2, para 1, and she came to our hospital for the chief complaint of abdominal pain and difficulty of defecation for 3 days duration. She had also nausea and vomiting. She had loss of appetite and weight loss before these acute symptoms developed. And because of that, she visited our hospital, and she was initially evaluated by a surgical team because she had this nausea and vomiting. And upon our evaluation in our department in gynecology, retrogradely we have identified that she had a pregnancy that was there for 25 years back. And at that time, she was admitted because of prolonged labor, and induction of labor was tried so many times, but it was not successful. And after that, the physicians, they told surgery, cesarean section by then. And because she was afraid of this surgery, disappeared from the hospital before the day of the surgery. And after that, she stayed for 2 years, and the abdominal girth was getting lesser. So she was able to palpate this abdominal mass for 25 years, but there is no significant pain. She was doing her usual activity without problem. And now she was presented with her only son, who was 28 years then. Then after admitted in the surgical ward, she had investigations, X-ray was done, and that shows some sign of intestinal obstruction, as well as this fetus. That is when they try to request ultrasound, and the ultrasound shows intrauterine pregnancy with 28 weeks size, and then they contacted us for evacuation and delivery. Then upon our evaluation, we identified that the woman was in good vitals, and the other systems were in normal condition, but on the abdomen we were able to palpate abdominopelvic mass. On bimanual examination, we were also able to see that there is some deflection, or the cervix was not in position, so we are suspecting this possibility, and then that's why about the woman, and she told us all this history. The history that I told you comes after we identified this condition. So after investigating, we did laparotomy, and it was not we identified this mass with adhesion with the omentum and the left side of the infundibulopelvic ligament. And from the mass, we were able to see at least the head, the arms, the legs, and it was developed at the level of the buttock area, but it was obvious that this mass was there for a long time. And post-operatively, we followed her. The mother was in a stable condition, and the surgery was not that much difficult, and the patient was discharged after 7 days of stay in the hospital. So to say something about lithopedion, it is a Greek word for stone child. Litho means stone, and pedion stands for child. And it is a very rare condition. And it occurs when there is a fetal death, and that fetal death, when it ends up in calcification, and when it's changed to bone and cared for long time, we call it lithopedion. So it is a very rare, and we have around 330 cases reported before. And it develops when the fetal limb ensues and the fetus is too large to be absorbed, and the immune system will consider it as a foreign body and induces a calcium-rich substance deposition, thereby turning the fetus into a stone. So in the case reports, we can see that women can retain this mass from 4 to 70 years even. So the age of the patient, even there are reports of this lithopedion occurring in 100 years old women also. So possibly when a fetus dies during abdominal pregnancy, it can undergo complete absorption, or if not, if it is big one, it can go suppuration, mummification, calcification, and adipose formations. The symptoms are usually it is asymptomatic, but when it causes symptoms, they come with pelvic pain, wet sensation in the abdomen, and compression symptoms in the urinary bladder and the GI system. And the diagnosis can be done with typical history and physical examination that suggests a pelvic mass, and it can be confirmed by an X-ray usually. And it is common also to diagnose this incidentally and even during laparotomies. And it is usually surgical unless there is a contraindication for surgery. So the possible complications are cephalopelvic disproportions in future pregnancies. So there are cases where a woman can get pregnant and give birth while she had also lithopedion inside. Urinary and rectum perforation, intestinal obstructions, abscess formations, and infertility is possible. So this tells us that the occurrence of this lithopedion can occur in areas where there is poverty, and whenever there is lack of health literacy and awareness, and whenever there is distress. These are my references. Thank you.
Thank you, Dr. David, for the good presentation and actually the rare case we may have in obstetrics. Please, before you go back to your seat, we will have a session of questions, and you will have a seat on the podium. May I call Dr. Dukundan Alexander? I'm very sorry. I'm very sorry. May I call? Oh, are you?
Good afternoon, everyone. My name is Dr. Dukundan Alexander. I'm going to present about my research findings entitled The Prevalence and the Factors Associated with Respectful Maternity Care in Healthcare Settings in Musanze District. Here is the outline. First of all, we would like to know what is respectful maternity care. So as you see, respectful maternity care is the care that preserves the dignity, privacy, and ensure confidentiality, but also which is free from harm to mother and allow them to make the informed choices about their treatment. So when they are not given respectful maternity care, what happens? Some of them, they face mistreatment, which lead to maternity service underutilization. Then they won't come to attend the skilled birth, then which will increase maternal, neonatal morbidity and mortality. This is the information that we already have. We have the prevalence of respectful maternity care in Ethiopia with 87.8%. In Kenya, 80, and in Tanzania, we have 85, and in Eastern Province of Rwanda, we have seen that respectful maternity care was estimated at 70.2. As I said, the lack of respect for maternity care lead to decreased maternity service utilization rates, which contribute to increased maternal mortality and morbidity. In my research, the question was to determine the prevalence of respect for maternity care among the healthcare settings of Musanze district, and also identify the factors associated with respect for maternity care. We enrolled 335 participants from 7 health centers and 1 hospital, Ruhengeri Referral Hospital, and we enrolled them on first come, first served basis according to the convenience, and all the mothers who delivered in 6 weeks before the study and those who delivered by the time we were doing research were enrolled. And those who are unable to provide consent or who were critically ill or diagnosed and documented postpartum psychosis and depression were excluded. So we used the data collection tool adapted from the study done by Afran et al., which was done in Kenya and validated in Kenya, rural and urban places, also in Ghana and India. In data analysis, our prevalence was determined using descriptive statistics, and the factors were identified by learning logistic regression models by identifying a 95 confidence interval with significant level below 0.05. As the findings, we have seen that most of our participants were aged between 25 and 34. Most of them got married at the age between 15 and 24, and they were coming from a rural area, and most of them were married. Their obstetric characteristics, most of the participants who enrolled were primiparous, multiparous, and most of them attended antenatal care more than 4 times, and most of them delivered vaginally and delivered at the level of the hospital. As the results, we saw that 65.1% of our participants received respectful maternity care, whereas 34.9% didn't receive respectful maternity care. Here is the proportion of the subdomain of respectful maternity care, where you can see those who received the dignity and respect was rated at 84.8, and autonomy and communication was 73.1, but also those who received social support was 72.5. to identify the factors associated with respectful maternity care. These are social demographic factors which were associated with respectful maternity care, which includes employment status, residence, marital status, socioeconomic status, health insurance type, and the education. Among the related factors, those are the significant factors which were identified, and those were significant below p-value of 0.01 were enrolled into multivariable logistic regression, where we found that employment status were associated with respectful maternity care with the odds of 17.75, likelihood of getting respect compared to those who were unemployed. Whereas on those who were using other insurances like MMI, RSSB, were having higher chances with order of 4.17 of getting a respect compared to those who were using community-based health insurance. Mothers who were primiparous were likely to be respected compared to multiparous to the odds of 2.7 times of getting respectful maternity care compared to multiparous. On the other hand, mothers who delivered by cesarean section were 3.84 times of getting respectful maternity care compared to those who delivered by vaginary. And those who delivered at health center were most likely to get respect to the odds of 3.72. Those who delivered during the daytime were likely to get respect to the odds of 3.11 compared to those who delivered during the nighttime. What does this mean? Comparing to where this study have done and comparing other countries, our findings were low compared to the study done in Kenya, Ethiopia, and Tanzania. And also, it was high compared to the study done in Nepal and Nigeria. This was due to, in these studies, there was a lack of standardized tools that were used, and also different social cultural differences which affect the way our mothers receive the care. When it comes to the factors, the employment status affect the economic and cognitive empowerment for the women, which gives them the confidence to speak up for their rights. Whereas, for the mothers who were using community-based health insurance, they were claiming the long time it takes to access to care. Different processes, they need to go to copy their IDs, so it takes a long time compared to other mothers using other health insurances. For multiparous women, they're always having higher expectation, and on the other hand, primiparous women are not yet familiar with the delivery process. So in the level of health centers, we have low load of patients and small number of healthcare providers. We had limitation, but also we had strength of using this tool which was validated in the context similar to ours. Here are my recommendations, and these are my acknowledgements. Thank you for your kind attention.
Thank you, Doctor, for the good presentation, especially what we are doing in our everyday practice. We call the other presenter before we go for lunch, Dr. Emmanuel Shimimuremyi, who is going to present her research results.
Yes. Thank you, Dr. Emmanuel. So the IT can display the slide. So the reason why I chose to conduct the study on GDM, so nowadays, so to conduct a good antenatal care, normally it started preconceptionally. So we have to screen and even to predict in order to make a better prevention. So nowadays we know that you can screen preeclampsia in the first trimester, you can screen genetic abnormalities in the first trimester, even you can screen other conditions, because the trend nowadays is to move everything in the first trimester, because in that regard you can make a roadmap for the pregnancy to classify the women in high risk and low risk pregnancy. If I can continue my talk objective, I conducted the study on gestational diabetes during a pregnancy. This is my talk objective. And as you know, GDM has been started 5 decades ago. And then in 2008, the HPO, the hyperglycemia adverse pregnancy outcome conducted. Sorry for the microphone. The HPO study that was conducted in 2008 shown that there is a positive correlation between blood sugar between 92 and 118 below the diabetes, because in that regard it has been shown that there is if the mother has the blood sugar within that range, there is a risk of macrosomia and the risk of neonatal intensive care unit admission, and there is increase of cesarean delivery rate. So in that regard, the International Association of Diabetes in Pregnancy has adopted that we should start screening the gestational diabetes by using single step, because nowadays we know that there is 2 steps. One step is when you give the woman the blood sugar 75 grams between 24 and 28 weeks, and then you measure the blood sugar, the fasting, and 1 hour and 2 hours. So we saw the threshold. And then in 2018, the WHO recommended that we can start screening the GDM. So my problem statement is in Rwanda, we didn't have enough data about the GDM. My research question was to assess the cumulative incidence rate and to see if there is any associated risk factors associated with GDM, and to assess the effect of GDM on the development of neonatal and maternal outcome. So if I go to the specific objective was to assess the relationship between demographic factors and the effect of GDM on maternal-fetal outcome. So my literature review, so you can see that around the world, nowadays, because of lifestyle changes, diabetes is increasing. About 371 million are affected by diabetes, but in Africa, around 14 million women are diagnosed with diabetes, but in 2030, the risk will be about 50%. So the global rate of GDM is around 14%, but you can see that there is the highest incidence is in Southeast Asia, and the lowest is in Northern America and in Caribbean. And you can see that in Africa,
the rate is 14%. In East Africa is 60%, West Africa 14%. In Rwanda, the rate was 8%. And in Ethiopia, the cumulative incidence rate was 17%. And the cesarean delivery was increased among the women who has GDM, and even pregnancy-induced hypertension, and even PPH. There was a study that was conducted in Rwanda by Professor Rurisa in 2018. It was conducted in both rural and urban health centers. So in rural areas it was 2%, and urban it was 4%. So my design of my study was a cohort study that was conducted at King Faisal. So I got the ERB approval. So those are my thresholds that we were based by the International Association of Diabetes. The fasting should be above 92, and 1 hour 180, and 2 hour 153. So my sample size was 255. My population was pregnant women between 24 and 28 weeks. So we did the statistical analysis by doing the descriptive analysis by summarizing our categorical data by proportion, and numerical data by means and standard deviation. So, and we did the analytic analysis by bivariate analysis and the chi-square test and the multivariate binomial logistic regression to adjust the confounders. So the p-value, the results were statistically significant when the p-value was lower than 0.05. So as I can continue, so the inclusion criteria were pregnant women between 24 to 28 weeks. So my results, that is my flow diagrams. We start with screening the population of 304. So, and we excluded 9 women because they refused to consent the woman. At the end, we have 2 arms. Those who were diagnosed with GDM were 55, and they were exposed, and those who didn't have GDM were 275. They were non-exposed pregnant women. So the rate that we have 19% as a cumulative incidence, and then the BMI was 30, and the mean age was 28. And then we found that many participants were coming from Kigali. And then by screening, if you use only the fasting blood sugars, you can miss up to more than 50% if you see only the fasting blood sugars. And if you go with the traditional risk factors for GDM by assessing from the past medical history, if the mother has like unexplained fetal demise, or had like the mother is obese, and you can miss up to 21%. This is my table for demographics. After adjusting the confounders, I found that obesity was associated with GDM. So for bivariate and multivariate logistic regression, I found that only the familial history of type 2 diabetes in the first degree relative family and macrosomia was associated with diabetes. And the effect for GDM for the development of adverse outcome, it was hypertensive disorders. I saw that the woman in the arm of the woman who had GDM, there was associated with the development of hypertensive disorders, polyhydramnios, and the cesarean rate was increased. And for the babies, I saw that the neonatal NICU admission was increased macrosomia and hypoglycemia after delivery. So my discussion, I found that so my results were very high compared to the study that were conducted in Tanzania, Ethiopia, and even Africa. But it was very low compared to the study that were conducted in Uganda and in Southeast Asia. And at the end, I found that BMI and type 2 diabetes and the previous baby with macrosomia, there was an association with GDM. And then this is, my findings were similar to the findings that were done in Ethiopia and in Uganda. And at the end, we found that there was no association between GDM and preterm delivery and the operative vaginal delivery and the unexplained fetal demise. So my strength of my study, it was a cohort studies. So we tried to abide to the World Health Organization. So our limitation, we didn't have the data about the pregnancy, BMI, and our study was only focused for one centers. So we recommend that exercise and diet is a key during pregnancy. And then to generalize our finding, we need to expand our study for other study in order to have the sample that can be representative to the whole country. Because nowadays, we have to answer the question that can we do a universal or a selective screening. So we need to do the study in the other centers to have that, to make a kind of protocol or a guidelines. Thank you.
Thank you to Dr. Manuel for the presentation. And in constraint with time, we are very sorry, we will not have questions. And those who are having questions, please write them down on the paper, or you will be asking them when you meet the presenters. So let us give them a very huge applause, and then they can join their seats. Thank you for your presentation. Ladies and gentlemen, let us go for lunch. Thank you.
Yes, let us go for lunch. Just a few housekeeping announcements as we go for lunch. Lunch is for 40 minutes. So we're encouraged to be here 10 minutes to 3. The other thing is that as we walk to lunch, you can see the exhibitors down outside because they want to hear from us and they want to tell us what they're here for. Thank you. Please, let us go for lunch.
Welcome to Mega Life Sciences, established in 1980 and a public company since 2013. With a global presence in over 33 developing countries and GMP approvals in over 50, Mega is a leader in the health industry. Mega Life Sciences has proudly served the people of Rwanda for over 9 years, supporting health and wellness in the region. Our manufacturing plants span across the globe, ensuring the highest quality products for all. At Mega, we believe in helping people stay healthy as long as they live. We are passionate about women's health and focus on developing brands with the modern woman in mind. During pregnancy, nutrition is key, but diet alone may not be enough. That's where Mega Prenatal comes in. Small, easy-to-swallow capsules packed with essential micronutrients for a healthy pregnancy. Ferritone offers a breakthrough liquid in a capsule formulation, eliminating metallic taste and GI irritation for easy, assured iron absorption. Calcivita's small, vanilla-flavored capsules ensure optimal calcium absorption without digestive discomfort. For fast relief from pain, Gofen's unique clear cap technology delivers results in just 15 minutes with minimal GI irritation. Mega's portfolio includes a NAT 400, the purest form of natural vitamin E, Zeman for enhanced testosterone support, and a NAT cream for flawless skin with reduced stretch marks. With a wide range of innovative products, Mega Life Sciences is committed to your health and wellness, wherever you are.
Mega, we care.
Welcome to Mega Life Sciences, established in 1980 and a public company since 2013. With a global presence in over 33 developing countries, and GMP approvals in over 50, Mega is a leader in the health industry. Mega Life Sciences has proudly served the people of Rwanda for over 9 years, supporting health and wellness in the region. Our manufacturing plants span across the globe, ensuring the highest quality products for all. At Mega, we believe in helping people stay healthy as long as they live. We are passionate about women's health and focus on developing brands with the modern woman in mind. During pregnancy, nutrition is key, but diet alone may not be enough. That's where Mega Prenatal comes in, small, easy-to-swallow capsules packed with essential micronutrients for a healthy pregnancy. Ferritone offers a breakthrough liquid in a capsule formulation, eliminating metallic taste and GI irritation for easy, assured iron absorption. Calcivita's small, vanilla-flavored capsules ensure optimal calcium absorption without digestive discomfort. For fast relief from pain, Gofen's unique clear cap technology delivers results in just 15 minutes with minimal GI irritation. Mega's portfolio includes a NAT 400, the purest form of natural vitamin E, Zeman for enhanced testosterone support, and a NAT cream for flawless skin with reduced stretch marks. With a wide range of innovative products, Mega Life Sciences is committed to your health and wellness, wherever you are.
Mega, we care.
Welcome to Mega Life Sciences, established in 1980 and a public company since 2013. With a global presence in over 33 developing countries, and GMP approvals in over 50, Mega is a leader in the health industry. Mega Life Sciences has proudly served the people of Rwanda for over 9 years, supporting health and wellness in the region. Our manufacturing plants span across the globe, ensuring the highest quality products for all. At Mega, we believe in helping people stay healthy as long as they live. We are passionate about women's health and focus on developing brands with the modern woman in mind. During pregnancy, nutrition is key, but diet alone may not be enough. That's where Mega Prenatal comes in. Small, easy-to-swallow capsules packed with essential micronutrients for a healthy pregnancy. Ferritone offers a breakthrough liquid in a capsule formulation, eliminating metallic taste and GI irritation for easy, assured iron absorption. Calcivita's small, vanilla-flavored capsules ensure optimal calcium absorption without digestive discomfort. For fast relief from pain, Gofen's unique clear cap technology delivers results in just 15 minutes with minimal GI irritation. Mega's portfolio includes a NAT 400, the purest form of natural vitamin E, Zeman for enhanced testosterone support, and a NAT cream for flawless skin with reduced stretch marks. With a wide range of innovative products, Mega Life Sciences is committed to your health and wellness, wherever you are.
Mega, we care.
Welcome to Mega Life Sciences, established in 1980 and a public company since 2013. With a global presence in over 33 developing countries, and GMP approvals in over 50, Mega is a leader in the health industry. Mega Life Sciences has proudly served the people of Rwanda for over 9 years, supporting health and wellness in the region. Our manufacturing plants span across the globe, ensuring the highest quality products for all. At Mega, we believe in helping people stay healthy as long as they live. We are passionate about women's health and focus on developing brands with the modern woman in mind. During pregnancy, nutrition is key, but diet alone may not be enough. That's where Mega Prenatal comes in. Small, easy-to-swallow capsules packed with essential micronutrients for a healthy pregnancy. Ferritone offers a breakthrough liquid in a capsule formulation, eliminating metallic taste and GI irritation for easy, assured iron absorption. Calcivita's small, vanilla-flavored capsules ensure optimal calcium absorption without digestive discomfort. For fast relief from pain, Gofen's unique clear cap technology delivers results in just 15 minutes with minimal GI irritation. Mega's portfolio includes a NAT 400, the purest form of natural vitamin E, Zeman for enhanced testosterone support, and a NAT cream for flawless skin with reduced stretch marks. With a wide range of innovative products, Mega Life Sciences is committed to your health and wellness, wherever you are.
Mega, we care.
Welcome to Mega Life Sciences, established in 1980 and a public company since 2013. With a global presence in over 33 developing countries, and GMP approvals in over 50, Mega is a leader in the health industry. Mega Life Sciences has proudly served the people of Rwanda for over 9 years, supporting health and wellness in the region. Our manufacturing plants span across the globe, ensuring the highest quality products for all. At Mega, we believe in helping people stay healthy as long as they live. We are passionate about women's health and focus on developing brands with the modern woman in mind. During pregnancy, nutrition is key, but diet alone may not be enough. That's where Mega Prenatal comes in. Small, easy-to-swallow capsules packed with essential micronutrients for a healthy pregnancy. Ferritone offers a breakthrough liquid in a capsule formulation, eliminating metallic taste and GI irritation for easy, assured iron absorption. Calcivita's small, vanilla-flavored capsules ensure optimal calcium absorption without digestive discomfort. For fast relief from pain, Gofen's unique clear cap technology delivers results in just 15 minutes with minimal GI irritation. Mega's portfolio includes a NAT 400, the purest form of natural vitamin E, Zeman for enhanced testosterone support, and a NAT cream for flawless skin with reduced stretch marks. With a wide range of innovative products, Mega Life Sciences is committed to your health and wellness, wherever you are.
Mega, we care.
afternoon. We've just had a nice meal, but hold on tight. Hold on tight. So we got another very good round of sessions this afternoon. And I'd like to make a few housekeeping announcements. We are in this meeting, but we have so many people who cannot make it today here. So please, 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 please use your social media platforms and tell the world about our conference. If you are on X, former Twitter, please use the hashtag RSOG 2024 conference. And you will make sure that we retweet you and we'll make sure that your message is going across. So without taking further ado, I'd like to introduce our moderator for the afternoon sessions. We've talked a lot about maternal health in the morning. We are shifting the gear into another field, very, very, very important. And we're going to talk about cervical cancer elimination. So no one else is well positioned to lead and moderate this panel, apart from the one who is now our firstborn gynecologist, oncologist, freshly graduated from our University of Rwanda, a fruit of the 4x4 as we talked in the morning. He is a lecturer at the University of Rwanda. He also is a consultant at the Kigali University Teaching Hospital. He's a dedicated person, humble, down to earth, excellent. Allow me to introduce Dr. Kenneth Ruzindana.
I'm not sure if he was talking about me. But thank you for the wonderful presentation. I'm very humbled. So we are going to shift gears, as they mentioned, and this afternoon we are very privileged to be leading this session on cervical cancer. So we have talked about maternal mortality, but we are going to be having a panel discussion on cervical cancer, one of the most preventable and treatable forms of cancer. Yet it remains the leading cause of cancer death among women worldwide, and most especially in Rwanda. So we are going to discuss some of the strategies that the Rwandan government has employed to combat cervical cancer, and also we'll discuss some important and successful programs like HPV vaccination, the national screening programs, and I'm very delighted to introduce to you an esteemed panel of experts who bring a wealth of experience and knowledge to this discussion. So allow me to welcome our panel, our next panel. I'll first introduce Dr. Maniragaba Theonest. Please step forward and take a seat here. Is he here with us? I saw him earlier. Okay, I'll start with the others. I'll introduce Dr. Cyprien Shirambere. Yes, Dr. Cyprien Shirambere is the Director of Oncology Programs at Partners in Health, where he coordinates all the operations of Butaro Cancer Center of Excellence. So they are responsible for the biggest treatment cancer center in the country. So he oversees this cancer program, as well as the government of Rwanda's efforts to advance care in Rwanda. He's also a pediatrician by training, and also is an adjunct assistant professor at the University of Global Health Equity. I will welcome as well Madame Vestine Rijema. Is she here? Yes. We're very lucky to have Vestine Rijema also, who is works with Partners in Health and one of their leaders in the Women's Cancer Early Detection Program,
as a field manager. She's going to bring to us a wealth of experience in early cancer detection for both cervical cancer and breast cancer. And she works a lot with community health workers and providers on cervical cancer screening and breast cancer, including early cancer awareness and detection. We shall have, yes, Dr. Theonest is here. Dr. Theonest is the director of the cancer programs at the Rwanda Biomedical Center, but also he's a clinician. He's a consultant clinical and radiation oncologist at the Rwanda Cancer Center of the Rwanda Military and Referral Teaching Hospital. So he combines both experience with clinical and policy making. So he's going to give us an overview. And our next presenter, our panelist is Dr. Dawit Kassa. Yes. Dawit Kassa is also, I'm privileged to have him as our panelist. He's also my mentor and a gynecologic oncologist and one of the directors of the program at the University of Rwanda and the gynecologic oncology. And we are very honored. He will give us his expertise with regards to treatment. And lastly, but not least, I'll introduce Dr. Emmanuel Manirakiza. Dr. Manirakiza, who is also was my classmate, I should say. He's an obstetrician and gynecologist, working in both public and private, but very passionate on cervical cancer elimination. He's most importantly an independent consultant with Electa Foundation. Electa Foundation does a lot of work in Rwanda regarding cervical cancer screening, and he helps to run and manage some of their cervical cancer screening campaigns. He's also a national master trainer on cervical cancer screening and early detection. So this is our panel, and we are very happy to have you all. Thank you for allowing to be part of this. I'll start with Dr. Theonest. I think he's the boss now that we have at the Rwanda Biomedical Center. Dr. Theonest, we know that Rwanda has made notable strides towards cervical cancer elimination, by aligning mainly with the WHO global strategy for cervical cancer elimination. I just want to give you just a few minutes. I know there's a lot that you have to say, but I want you to just provide a broad overview of the national goals for cervical cancer elimination. And I just want you to highlight a few current epidemiologic status as well as the burden of the disease in Rwanda. So while you're speaking, I want you to just take us also through some of the challenges that we face in scaling up cervical cancer screening programs, especially in Rwanda. Thank you. Let's start from there.
Thank you, Dr. Kenneth. Good afternoon. It's my pleasure to be part of the RSOG 10th conference of RSOG here in Kigali, and I am very glad to be here. So I had prepared some slide. Maybe we can maybe appreciate 5 at least. Next one. Next. So let's start by there maybe. The first slide was telling maybe what has been happening through our cancer registry for the last 10 years. The previous slide. The previous, yes, that one. From 2007 to 2022, these are the data that are showing how we have been receiving many cases of treating cancer from Butaro, because last 10 years we have had Butaro Cancer Center of Excellence, and then our centers, including Rwanda Cancer Center. If we take maybe 10 years from 2022 to 2012, you'll find that the cases have tripled. Next slide. Cervical cancer and breast are the previous, the main one that we have, with the cervical cancer being the major in female, 10% of total cases that we receive. in 2022 was cervical cancer. And next slide. Next one. That one. 40% of our cases, adding the 26, which will be around 6% of our cases, are local advanced stages, meaning those are stage 3A, stage 3B, stage 4A, and metastatic, which is stage 4B. So meaning that if we evaluate, we don't put much effort in making sure that people are vaccinated and screened at early stage. We keep receiving people with local advanced stages, and then the curative intent treatment outcome should be poor. Then next slide, that one is showing now the survival for cervical cancer. As we see, when the patient are treated with concurrent chemotherapy that we give at Rwanda Cancer Center, the 1-year survival is around 82. The 3rd-year survival turns around 61. 5-year survival is 55. To increase this survival, we need just to, to find people at early stages, or, to prevent them to get this disease. The last one maybe, let's go down, next one. The strategy now that Dr. asked, WHO from 2010 to from 2010 from 2010 to 2030, we should be reaching the 90-70-90, which is a strategy that requires all countries that have signed this agreement to make sure that we have vaccinated 90% of our ladies of 15 years. Here we are vaccinating between 14 to 15. And then for those whom we found that they are eligible for screening between 29 to 49 years, we screen them with the eligible standard test. Here we are using HPV. And we make sure that for those who are screened, we treat the precancerous lesion and malignant lesion at 90%. Next. The vaccination achievement that we have been having since the last 10 years, we are around 90. So we are achieving that through the expanded program of vaccination, which is good. It has lowered during the COVID because we are used to be around 93. During the COVID, we could reach 90 because, there were a lot of school dropout. And this vaccination is being done in collaboration between Ministry of Health, Ministry of Education, and local governance. So during COVID, people were not attending very well, school. So that's why it dropped out. But at least, the good news is that we didn't go down less than 90. So we are achieving it. The issue now is about screening. That's what I want to tell now for the next slide. Next. The model we use in screening is we go through the community, we work with health centers and district hospitals, and then the referral hospitals are there just to receive cases which are suspected for diagnostic and treatment. The major one is Sashika, Sashibe, Butaro Cancer Center of Excellence, and Rwanda Military and Referral Teaching Hospital. Next slide. So these are the coverage of hospitals. The major hospitals that have achieved 70% is Gichumbi and Karongi now. Others are down under 70. We are trying our best to accrue the numbers. But if you go for the next slide, you will see that where we have the red, we are around 26, less than 6%. But for where we have now the green is about 70. So Gichumbi and Karongi, they are on 70. We have achieved the 70. But Burera and Kayonza are still down. Generally, Eastern Province has been covered, as compared to Western and South. So this time around, we are making sure that we cover, first of all, we implement the program in the remaining 8 districts, which is Nyabihu, Rubavu, Rutsiro, Ngororero, Nyamagabe, Nyaruguru, and Gisagara, if I remember very well. So we still have challenges in coverage for cervical cancer screening. First of all, to make sure that the districts who don't have program, we implement it there by making sure that we retrain nurses and we support them with equipment. But also we have issue for funding, which is the major issue. But also the other issue is about turnaround of, the healthcare providers, who live there, health facilities. Others, they are the major one, awareness, as we can mention many. Thank you, that's the overview. And I think I have answered all your questions. Thank you so much.
Thank you very much, Dr. Theonest. I think in view of this, our cervical screening programs are still very low. The penetration is very low. So I want to
The coverage is 22.
Yes, 22% is extremely low. Our WHO recommendation is at least 70%. So I want to tap into the expertise of Madame Vestine Rujema, who is PIH's expert on women cancer and early detection. She's also a midwife. So I just want to just take us through your experience with Partners in Health and in your work with in Rwanda. How has your organization approached mobilizing and educating communities to promote early detection towards improving patient outcome? Just take us through some of your work briefly and how you've managed to do this.
Thank you. As PIH, on the point of mobilization, we train community health workers on cervical cancer, what is cancer, the signs and symptoms of cervical cancer, and also the risk factors and the impact of early detection. After training the community health workers educating the community about cervical cancer screening and addressing the myth and the local beliefs. And after educating the community during evening gathering or people assembly in the village, and after educating, they do also the home visit, home to home, and they identify the eligible people. After identifying them, they encouraging them to go to do screening of cervical cancer. And also the PIH organized the public awareness via radio, social media, and the other. And also we have mobile health technology where we send SMS to remind the women to go to the nearest health facility to do cervical cancer screening. And also with collaboration with MOH, we integrate the cervical cancer screening into primary health care, where the nurse and the midwife, they do HPV sampling, VIA, thermoablation, and some of them, they do also RIP, where the woman can go at nearest health facility to receive those services. And also we have a service we call patient navigation, where the patient navigation have a role to assist the patient where who is confirmed with cervical cancer or who is screened positive to overcoming barriers to care. The component of patient navigation is to do education and also to do advocacy for resources, for transportation. PIH has the fund for social support if the patient has the problem of ticket. The PIH have the fund for social support. And also the patient navigation have a role also to do psychological support. I think it's okay. Thank you.
Thank you, Madame Vestine. The Dr. Manirachiza, I know you have been involved with as a consultant with the Electa Foundation, and I know Electa Foundation is doing a lot of work with regards to cervical cancer screening in Rwanda. So I want to just tap into your expertise on this. I just want you to just highlight some of the contributions that your work and that of Electa Foundation has had in raising awareness for screening and also treatment programs across the country. I want to listen from you from that.
Thank you, Dr. Kenneth. I thank RBC because as partners, Electa Foundation, partners in health, and others like ICHAI, they manage to work together under leadership of RBC. So after looking the problem, which was eliminating cervical cancer as they can't bide on a global strategy to eliminate cervical cancer, we have achieved already vaccination more than 92%. Now the problem was cervical cancer screening and early treatment. As you see, you look the number from 2008, we was at 8% of screening. Now we are around, as they said, above 22 up to 28%. We still have a big problem to do. With Electa Foundation and the PIH, we managed to initiate 2 models of screening. One was called FASTER, which stands for Faster HPV Detection or Screening. A stands for Affordable Cost per Woman, where we managed to reduce the cost of HPV test cost per woman from around $25 per woman to around $5 with the partners. And we develop also a systemic tracking of the woman, where we recruit a woman and being screened. After that, we follow the woman through our system like HMIS, like normal message. We send the message to the patient and telling them the result, or if they are positive or negative, to come back for via triage. Also, a timely diagnosing and treatment, because we adopt a system of screening and treat. Once we diagnose, we treat on the site depending on the lesion. If a precancerous lesion is less than 75%, we treat locally by thermoablation or lip machine if it is above 75%, or if it is invasive cancer, we transfer the patient to the referral hospitals for management. So, a part of mobilization and awareness, we have trained more than 5,006 common health workers and community health workers, sorry. And we have also trained the nurses and the midwife who give services at the local where the patient lives. It means we can get mother in the market, on the street, if I can say, in the door-to-door by community health workers, and they come for screening. Once they come to our clinic, they do self-sampling, most of them. And after doing that, we send the sample to the lab. We move the lab to the district level where we can do PCR on the district hospital. After 3 days, we can give a result by CMS. We can send a CMS. If the result is negative, the mother or the woman don't come back. Then if the result is positive, we call them at least 3 times, and then they come for via triage. Through via triage, when the result is negative, we give an appointment after 3 years when they are HIV positive, and or 5 years when they are HIV negative. If they are positive, then according to the extent of the lesion, we can treat according to the protocol. That's what we are doing in this cervical cancer screening. And I can tell you that with Electa Foundation, if you see the 3 first district hospital who managed to be above 70%, like in Gichumbi, where we are about 90%, and in Karongi, where we are above 70%, it was with Electa Foundation and all the team, RBC and the PIH. What I can add from that, Electa, PIH, and the RBC also set a second model called, maybe we are talking about cervical cancer, but that model also called the 2-in-1, where we managed to screen cervical cancer and breast cancer at the same time. If you come for the cervical cancer, you have also a chance to be screened for a breast cancer also, or early detection. So that, in general, what we are doing.
Thank you, Dr. Manuel. Dr. Dawit, because I think you are an expert gynecologic oncologist and involved in the daily management of patients with cervical cancer. I know Rwanda is working very hard towards one of the pillars for the WHO cervical cancer elimination strategy, which is to have at least 90% of women diagnosed with cervical cancer being able to receive treatment. Now, as somebody involved in the field and in the training, I just want you to take us through, some of the advancements and challenges in treatment and management of cervical cancer in Rwanda. You can just take us through some of the treatment options that are available in Rwanda with regards to cervical cancer.
Okay, thank you, Dr. Kenneth, and thank you for having me here. When we look at the WHO 2030 elimination strategy, we see the 90-70-90 objectives. And of these objectives, the vaccinating more than 90% of eligible girls is already achieved in Rwanda. And the two other pillars of objectives that are remaining include the coverage of screening and providing treatment for those women who are positive after screening. So when you see, for example, mass screening strategies, you can screen, the more you screen, the high probability that you're going to get pre-cancer and also early cervical cancer patients. So the next step is going to be to have a human resource capable of treating those women with pre-cancer disease and early cervical cancer. So that is where it comes, the human resource development. So in the Rwanda context, we have the first GYN oncology fellowship training program that have been here since 2 years back. And the first cohort of 2 fellows have already completed their training, and Dr. Kenneth is also one of the trainees that have completed the GYN oncology fellowship program. So now with 90-70-90 model, unless the human resource or capacity is built to handle those cases that are going to be found during screening, is going to be very difficult. It's going to be a very challenging aspect of the 90-70-90 WHO target set for 2030. So saying this, coming to the question, currently a comprehensive gynecologic oncology service is being provided at 2 of the teaching hospitals, Rwanda Military Hospital, CHUK, University Hospital of Kigali, and also at CHUB. So this includes comprehensive surgery with different radicality for gynecologic malignancies, including cervical cancer. And for those patients who have more advanced disease, chemoradiotherapy is being provided at the military hospital and at the Butaro hospital. When it comes to one of the challenge, I think one of the, maybe this could be an input when it comes to the 70% screening coverage, okay? So if you see, during OBGYN residency training program, when an OBGYN is finish or completes his training or her training, majority of the training so far, the OBGYN is not equipped with the comprehensive skill to have like a lip treatment. So this is going to be like in-service training after graduation. So I think incorporating cervical cancer screening and treatment both for undergrad medical students and also for during residency training program could increase the number of healthcare providers that can provide this service comprehensively and also increase the screening coverage. Okay, thank you so much.
Yes, thank you, Dr. Dawit, for the comprehensive explanations. I'll get back to you again, but I want to listen from Dr. Cyprien. I know Dr. Cyprien is the director of the oncology program that introduced cancer treatment in Rwanda through Partners in Health. And he has, of course, lots of experience with regards to both policy and the nitty-gritty that goes with treatment. So I know that any type of cancer, leave alone cervical cancer, requires multidisciplinary care teams, towards, aimed at improving patient outcomes and progresses, Now, I want you to take us through, I know you are both a clinician and a policymaker. What are some strategies are in place to enhance, treatment efficacy and patient adherence once on treatment, as well as follow-up? What systems do we have in place? Do we have multidisciplinary teams working around treatment for cervical cancer? How do they work? How do you manage this very complex intricacy of cancer management? And I'm very sure your patient volumes are also very high. So I want to listen from you as both the program director and an expert in the field.
Yes, thank you very much, Dr. Kenneth, for giving me an opportunity. And first of all, I want to thank the Society of Obs and Gyn for organizing this impressive meeting. I think this is a nice opportunity for scientists to meet and share their experiences, and we have been missing these opportunities, so I wanted to congratulate you for this achievement. I also want to thank you for inviting Partners in Health to share our experiences on how we work in collaboration with the Ministry of Health to advance cancer control in Rwanda. I also want to thank my colleagues. I think my job will be easy because most of the aspects have been covered. But I just want to share what I have experienced in my past 10 years in this role, because many patients with cervical cancer have passed through my hands, and not because I'm a gynecologist or a clinical oncologist, but because my work, my job included to helping these patients to navigate through a complex system, as you mentioned. So to answer your question on what strategies we are using, I can summarize them in one word, which means collaboration. So cervical cancer is one of the diseases which is a case study for collaboration. You cannot pretend to address cervical cancer alone. Whether you are a gynecologist or an oncologist, so you will need many people to help you. That means surgeons, oncology surgeons. You need nurses. You need the preparative care expert. You need oncologists. So our job at Partners in Health, first of all, was to put in place a care delivery model. So basically, the cancer center in Butalo, which was established in collaboration with the Ministry of Health. When that center started, the focus was really to identify most prevalent cancers and put in place a program that could help those patients, to survive. Because we believe at Partners in Health that where you were born should not determine whether you live or die. So we believe that access to healthcare is a human right. So we worked very hard to put together a program. It was not easy, but we worked very collaboratively with the the teaching hospitals in Kigali. Dr. Diomed is looking at me, so he knows very well what I mean. So to provide chemo in Butaro, to send a patient to Kigali for surgery, and we worked with the Rwanda Military Hospital to build, to establish the radiotherapy center. And I have some good news for you today, is that in November, our first brachytherapy in the country will be launched. So yes. Yeah, so those who work there, you can see that the construction of the bunker is done, and the machine has been ordered with the funds from Partners in Health. And Dr. Theonest is going to send a couple of trainees outside for a refresher training. So we hope that by November, we will have a comprehensive package now to manage a patient with the cervical cancer, because we have good surgeons in the room here, and that reminds me when we were struggling a lot with this, but now I'm very happy to see that we have a team of surgeons who can care for our patient with the early stage of cervical cancer. Because I can give you a testimony that cervical cancer is a cancer of poverty, actually. And it is a cancer that can be cured. It is a cancer that can be eliminated, because I have seen this happening. And I'm convinced that together we can eliminate this cancer. Some of the challenges that I see, one of them is funding. So we don't have clear funding mechanisms to eliminate cervical cancer. And I call upon everyone here to help us mobilize funds to eliminate cancer, and also to invest in evidence-based good ways of screening, because we have been having issues with the quality of VIA, all those things. So quality matters, but also fund is a big challenge. Thank you very much.
Thank you, Dr. Cyprien. I think we have learned something as well. I think for us who are involved in the treatment for cervical cancer, brachytherapy is very important and plays a pivotal role in the treatment of cervical cancer. So that is really very good news to hear. And hopefully, I'll open up our discussions to everyone. I think I'll take maybe one or two questions from the audience. If anyone has some questions, we can directly listen to you and have our panelists answer to them. Go ahead.
Okay, thank you. My name is Kiros. I work in Kiwakora level 2 teaching hospital. So we find a couple of cases of cervical cancer, but we face a big challenge with their management. One of the issues is diagnostics. So, pathology service, what I have heard so far is one is in Shiashipe and the other is in Butaro in the north, which is very, very far away from our hospital. So we diagnose them clinically, but we cannot treat them because we need to have the proven diagnosis. For this, we try to communicate with people in Shiashipe as well as in Shiashika, but still, the diagnostics is an issue. Even they cannot treat without diagnostics. Now, again, though, we want the clients to go to Kigali or Butare. They don't want to go. When we ask them why is the reason, there are a lot of reasons. One is the economy, so they cannot afford to go here and there with their disease. And the other is a new environment, so they don't want to go in a new environment like Kigali that they don't know. So there are big issues with this, and we feel heartbroken, by the way, when we see cervical cancer cases, because we cannot deliver anything for them. So I think so far, over the past 5 months, we have seen like 6, 7 cases. All of them returned home. So, I feel how are you operating to orchestrate the way of the diagnostics? Because unless we do have a good pathology service, which is affordable, I think it's good for Rwanda if you have 2 or 3 places where pathology service can be done, but you need to integrate them very well so that, you know, without up and downs, patient can easily, you know, tissue can be easily shuttled and then processed. So can you give us some hints on this regard? Because we are always on our daily activities, we are a bit confused also how to handle such cases. Regarding screening, honestly, we don't screen in the hospital. I don't have any, I haven't seen, probably I may be mistaken, I haven't seen any even well setting for this purpose to be done. But I wish I could screen because I have training on cervical cancer screening, even to the level of colposcopy, but you know, we are not doing it because we don't have the good facility to do these things in an integrated way. So it's good also to visit us and then, you know, strengthen us so that we can help the poorly needy woman. Thank you.
So I think it has a lot of policy, and so Dr. Cyprien with Dr. Theoneste, I think you can take turns to respond to him.
Yeah, thank you, Kenneth. So with the permission from Dr. Theoneste, I'm going to try to address some of the questions from the doctor. So for screening, just wait a bit, we are coming. So we are screening district by district, and everywhere we go, we leave there a system, okay? Which works from community healthcare workers to the hospital level. So screening will actually be done by nurses in health centers, and they will be sending you just patient to do thermal ablation or lip. So we are coming soon. I think, to be honest, yeah. So for diagnosis, I think currently we have 4 or 5 histopathology lab in the country. The nearest one to you is Sehashibe. But should you feel that it is not enough, the pathology lab in Butaro, we serve 24 hospitals, including Chibogora. So I can give you a contact person that you can contact every time you have a sample to send. And I promise to give you the result in 1 week. Okay? And if a patient has social issues, as Vertine said, we have some funds to support a vulnerable patient. We give them free meals in the hospital. We give them a round-trip bus ticket, and we have a hostel to put them before they can go home. So I think that will be quite enough to help your patients. I think that's all.
So I think Dr. Theoneste will also touch how the Ministry of Health and RBC plans to, you know, sustainably introduce some of these services, because I think our colleague talked about some of his frustration, which I really understand. You know, you have a very trained person who is able to do all this work, but they don't have the equipment, the necessary systems in place so that they can use, you know, as somebody who's heading the cancer unit in RBC and the Ministry of Health, surely there should be some plans on how to sustainably introduce these services in at least selected hospitals. What do you have to say about this? I don't want to dilute his question, but I just wanted to emphasize that.
Thank you. Thank you, Dr. Cyprien, for the good inputs and that you have shared with our colleague from Kibogora. I summarize that saying maybe the issue is about navigation to me, just to make sure that there is, you know, a patient identified. Then we used to have these navigators wherever you have a program. There is like a focal person, as Dr. Cyprien has said, who will be helping patients to know where they will do their histology, investigation, radiology, and then even to link them to treatment centers. That's the only issue that Dr. Cyprien has, you know, mentioned, and he has responded. So coming to the program, For a program to run, we need at least three things. One, it's about infrastructure, equipment, and human resource. So for the program now, as we are now making sure that we implement this program all over the country, we have now reached the 22 districts, and we are remaining with 80 districts. In those districts, it means that all the health professionals that we should be teaching, all the health centers are not trained, one. So we need to make sure that those remaining, we give them the training. But also, in order to do screening, we need to give them kits. We have like the sample kits that we use for screening. So for all the districts that I have reached, I think where there is an issue, we supply them with kits, but we still have an issue of funding. Sometimes you may be lacking them because you don't have funds to support, and this issue, I think, will be sustainable while the CBHI maybe takes over, so that our facilities will be procuring through RMS when time comes, so that they can sustain it. We need to be realistic. And then I am sure here Professor Nasumu Moyangi is looking at me, because he has been calling me for some equipment that should be delivering, but we did not deliver, because at some point there were some provisions. Some people took them while they have promised to give, and then now I am struggling to find them, because you don't have a sustainable budget to make sure that we have all those equipment, sample kits that we need to support with the whole country. We need to understand this. And Dr. Sprie did not mention this. When we are enrolling this program in all over the country, the most expensive issue apart from training is about these kits. They are very expensive. One test is about 20 USD, but that is for the kids. The juniors, yes. The cost that the 20 USD I have talked about, it's the cost for the whole screening. So it's too much. But we are making sure that at least in the district where we have not reached, we train their nurses and some doctors at the DH, and then we support with the kids. Then we keep now working with them to support wherever there is stock out. That's what I can mention.
Maybe. Let me just take this up with you, because you are still in the hot seat. Regarding, I think I want you to come out openly and tell us what RBC is doing about integrating chemotherapy into community-based health insurance. How are we going to do this? I just wanted to put you on the spot on this, because I don't have anyone else to put on the spot. How are we going to, what are you doing about this? And I know there are many initiatives, but just update us.
Thank you so much. You know that CBHI is the first pillar of our health insurance scheme in Rwanda we have. Previously, all many services are covered by CBHI, but with cancer care, only some surgical services, radiotherapy being external that we had, were covered. But we want the whole comprehensive cancer care package to be under CBHI. Because the RSSB mentioned that they have limited funding, so the Minister of Health pushed through the government to make sure that cancer care package should be on CBHI, including systemic treatment whereby chemotherapy is. So the government has managed to do resource mobilization to make sure that funds can be available to cover the chemo package. However, we did not think that the whole cancer continuum, including maybe the whole cancer continuum, should be treated. So Ministry of Health has partnered with some consultant institution to make sure that they elaborate a core package that include screening, surgical, radiotherapy, systemic treatment that will be covered by CBHI. That exercise is done. The next stage that we are working with our partners, including PIH, SPRI is here, is to make sure that we elaborate an operationalization framework which will make sure that, which will define, which will be now the treatment centers that will be delivering that comprehensive package. That's one. Who will be delivering it at what will be maybe the basis. The first basis will be that core package that was approved by the Minister of Health. Second will be the treatment guideline, which is available. Next week will be, maybe I'm sure some of you will be invited to join us to approve that framework. While that framework will be approved, so we'll be knowing who will be providing this, and then RMS maybe will start preparations to be on board so that they can start procuring those treatments so that they'll be available here in Rwanda under CBHI. But after that workshop, that would need to be approved by Minister of Health, and then it is not, in my powers to decide when. But this is something that has been approved to make sure that soon, while that operationalization is done, people will be communicated. I think we can't take many months. Maybe Sprie has more to say.
Yes, I know this is in the mind of many people, and many people want to know where we are now and what is remaining. So to summarize what my boss just said, so now we know how much money the government will have to, how much money Mutuel will have to add in order to cover the basic chemotherapy drugs. So we know. And the Ministry of Health has approved, RSSB has approved, Minecofin has approved, and Minecofin has identified sources of extra incomes. Because the RSSB approach now is, okay, you want me to cover oncology services? Then they look at the government, give me more resources. Because the money I have now can only cover what we have now. So RSSB has identified extra sources of funds, which will include, so basically all the banks will be giving a portion of their interest to RSSB. So now the file is with the PM office to approve that we use those extra funds to prioritize cancer, because there are other things which include rehabilitation, SAMI services. So finger crossed, we think that the high leadership will approve that cancer is given a priority, and then we will be able to move quickly. So hopefully by next year, we will be able to have CHK, CHIB, Kanombe start to provide cancer care chemotherapy for the patient. I think that's what.
So the when is not answered, but it is soon, to be honest with you. And among the people who need that chemotherapy, I am among the prescribers. So don't worry.
Thank you. Can we have one more question? Yeah.
Thank you. Mine is not a question, but it's like a supplement about cancer tissue diagnosis that my colleague is facing in Kibogora. So Partners in Health, the focal person being Dr. Deoru Hangaza, has a platform where the time interval between surgery and getting a pathology result was more than 400 days. But it has decreased with the software and measures in place to less. But now the issue we have is transporting the tissue from the respective hospitals to the offices in PIH in Kigali. The vehicles are released only on condition that the samples are like 10 or 20. So I'm requesting RBC personnel. We have RBC vehicles moving almost every day or every week from upcountry to the town. So just like drones are cross-cutting in the Ministry of Agriculture and Health, I think your vehicles can also help in sample transportation. That's where the big problem remains. About when, then after diagnosing and confirming the diagnosis, then referring the patient from different hospitals, especially in the West, to come in Rwanda Military Hospital or go to Butaro. So that equation is not yet solved. I face the same problem as my colleague. Thank you. So Dr. Theoneste can help collaborate with the division of vaccines in RBC to transport those tissues. Because hospitals, we have been advocating, but they haven't changed. They release the vehicle, the driver, and the nurse when they have enough samples.
1 minute, Dr. Theonest.
Thank you. The issue of sample transportation has been discussed even some months ago with the Society of Pathology. We have a lot of priorities, to be honest with you. So we consider that a proposal. We needed to study with different experts, and then we will see if we can also define a policy and discuss with stakeholders to see if there may be any framework in which we can operationalize that. Thank you so much.
Thank you for, I think, let's give a round applause to our panelists. Thank you so much for sharing your expertise. I hope we have had a great insight into cervical cancer elimination strategy in Rwanda. Thanks to our experts. Thank you so much. Thank you for your inputs, and you could take your seats. Thank you so much. Please give them a hand clap again as they move back to their seats. Okay, next, I would like to invite Dr. Haytham Hamad. Hopefully I pronounced his name well. He's just going to briefly talk to us about a nouveau screening technique for cervical cancer. And I know I've piloted it at Shuka, so I've used it. So I know about it, but I want him to just speak briefly about it in a few minutes before we continue with our abstracts.
Thank you very much. Thanks. Actually, I should express my pleasure for being here today and for being in Rwanda. Today, we want to introduce a new advanced technology in cervical cancer screening. Can we view the presentation, please? Our new technology are made by Austrian company which called TrueScreen. It's dedicated just to introduce this device which called TrueScreen Ultra. Just a brief about the cervical cancer. We have around 660,000 new cases worldwide, 350,000 deaths worldwide. Actually, the problem more in the low and middle income countries. Usually, most of hospitals use the pap smear and the HPV DNA and colposcopy to view and to screen the cervix and to screen the cervical cancer. Actually, our device will sit here where we can cover 70% of the cervical cancer screening. Briefly, let's see how our device works. Our device will not take any pap smear, will not take any tissue, will not take any cell, will not take any biopsy. We don't need the lab. We just emit some lights. We have 4 or 3 wavelengths, 4 lights, green, red, distant red, and infrared. We send those lights inside the cervix. It will pass through all the cervix layers, reaching the muscle and the connective tissues. When these wavelengths go inside the cervix and come back again to our system, there is an artificial intelligence database. Algorithms based on this artificial intelligence database will take care of the analysis of the result. Lights are not enough. We emit some electrical signals, very small, very tiny voltage, to the cervix. It will go through the layers of the cervix, then it will come back again. The same. We will use the artificial intelligence to detect the abnormality. By simple words, we study the impedance of the cervix cells against the lights, against the electricity. Then the system will give us a result, which is normal, abnormal. We have a small video for just 2 minutes, if we can run it.
A world without cervical cancer. Every minute, a woman is diagnosed with cervical cancer. With early detection, cervical cancer is preventable. It is estimated that 9 out of 10 women who suffer from cervical cancer could have avoided this disease if they had undergone routine cervical screening. All women of screening age, no matter who or where they are. A world without cervical cancer. Every minute, a woman is diagnosed with cervical cancer. With early detection, cervical cancer is preventable. It is estimated that 9 out of 10 women who suffer from cervical cancer could have avoided this disease if they had undergone routine cervical screening. All women of screening age, no matter who or where they are, should have access to affordable quality screening. Unfortunately, many women have limited access to high-performance screening tests, or choose not to be screened by conventional methods. Women who do undergo screening with conventional methods often wait too long for results and are sometimes lost to follow-up treatment. TrueScreen is a real-time, AI-enabled medical screening device that overcomes many of these problems. Women have confirmed that the TrueScreen examination is much less uncomfortable and confronting than conventional screening methods, such as a pap smear or HPV testing. There is no scraping of the cervix involved, and it provides results in real time. Using a disposable sensor, the tip of the TrueScreen device is placed gently against the cervix. There, it uses optical and electrical measurements to detect cellular changes in cervical tissue. These measurements are instantly analyzed by the AI-enabled algorithm to identify the normal and the abnormal, likely precancerous or cancerous tissue. TrueScreen's accuracy is comparable to or better than conventional screening methods. A result is provided immediately, enabling care to be managed in one visit. TrueScreen is easy to use, portable, and does not rely on supporting laboratory facilities. The exam can be conducted anywhere with the same ease and accuracy, enabling population screening in resource-constrained settings. Visit our website www.truescreen.com and learn more about TrueScreen.
You are welcome anytime to visit the website, truescreen.com. Actually, our technology is not only accurate, real-time, digital, no need for lab, just one visit, you get the result within 5 minutes, let's say, even with preparation of the patient, it's comfortable for patients. They have done a study for a big number of patients. They find that 82% of patients prefer TrueScreen because there is no scraping, there is no harmful procedure, and 2% only prefer the pap smear, and 16% prefer both or nothing. They prefer not to go to the doctor at all. Just a small comparison between the TrueScreen and the pap smear, very fast. TrueScreen is real-time, painless, just single visit, and you will have the report directly. Some low and middle income countries, they need around 4 weeks to have the result of the pap smear, and sometimes 2 or 3 weeks or 4 weeks even for the HPV DNA result. Pap smear for the patient, there is a delay in the result, sometimes 3 days, sometimes 1 week, 4 weeks, and we have to scrape the cervix. We have to take some, let's say, some cells, and requires many visits. Even if you take for the patient, if you take the pap smear today, you have to recall the patient to inform him for the result and what's the treatment. TrueScreen is just single visit, then you will have the result immediately. The clinic, there is no lab needed. It's portable device, actually, rechargeable by wireless. We have single-use sensor, which is very good for infection control. It's user-friendly, and it's accurate. The most thing I like in TrueScreen is the accuracy and the sensitivity. Actually, we have some, let's say, some commercial in some countries. I will not bother you, and I will not waste time with these. Just if you have time, you can check the website. We have the annual report for 2023 and 2024 is ready. We have China, Russia, Vietnam, Indonesia, Africa. We have Zimbabwe and Kenya, Saudi Arabia, Jordan, Palestine, Mexico, and Eastern Europe. Actually, there is some studies, some references for the technology and for how we can use the technology, how to make the triage in the hospital to use this portable device. I'm done. If you have any question, you are most welcome.
Okay, we shall ask him to return. Please keep your questions, and if you have any questions, we shall ask him to return. Thank you for sharing this nouveau device. We are looking forward to having it being put to use. So today we are going to have our last, but certainly not the least, oral abstract presentation by Associate Professor, I hope I pronounce his name well, Eyaya Misgan Asres. Dr. Eyaya Misgan Asres is one of our expatriates helping us with our 4x4 program and is running our program at Gisenyi Level 2 Teaching Hospitals. Dr. Eyaya, you're very welcome.
Good afternoon. Slides, please. So I'll be talking on stage art diagnosis and associated factors at the Babagan Specialized Hospital in Northwest Ethiopia. Currently, I'm working in the Northwest Rwanda. So I will be talking on this important topic. I have nothing to disclose. This will be the outline I will be following. And as a background, since we are talking about this issue this afternoon, I will not go much. And as you know, cervical cancer is the fourth most common cancer in women globally. And it is in the 2022 data with almost 604,000 women being diagnosed with cervical cancer each year, and 342,000 women are dying. 90% of these deaths are in lower and middle income countries, and the majority being in Africa. This is greater than the maternal mortality ratio that we were talking about in the morning. So deaths of women from cervical cancer is like 340,000. It's almost double the maternal mortality ratio that we were having. And 9 in 10 cervical cancer is being diagnosed again in sub-Saharan Africa. Women living with HIV are 6 times as likely to develop cervical cancer compared to women who are HIV negative. And most of these women with cervical cancer diagnosed at an advanced stage. Late stage diagnosis is also associated with poor disease prognosis and survival and drug resistance. So this is the statement of the problem. Since this cervical cancer is the leading cause of cancer morbidity and mortality in women globally, and since it is the most common cause of cancer death for women in 36 countries, and most of the cancer, cervical cancer diagnosis is being made in women in 23 countries of sub-Saharan Africa. And since it is the second most prevalent cancer in women aged between 15 to 44 years, and when we bring the data to Ethiopia, it was the second most common diagnosed cancer. We have a cancer diagnosis of 7,445 newly diagnosed cancers each year, and the second leading cause of cancer deaths in women, with close to 5,300 women being died of cervical cancer. And since most cervical cancer patients in Ethiopia seek healthcare at an advanced stage, we want to develop this program, and this we developed the research gap analysis, and we developed based on this conceptual framework. We did the study at a tertiary center. So these are the objectives of our study: to assess the stage of diagnosis and associated factors of patients with cervical cancer at Ababegion Specialized Hospital. And the specific objectives are clear: to determine the stage of diagnosis and to identify the factors associated with the stage. So this is the study design. We did a cross-sectional study, and with the source and the study population being those women with diagnosed with cervical cancer from January 1, 2021 to December 31st, 2022. It is almost a 1 year period. And we included a sample of 284 based on a statistical estimation. We determined the sample based on single population formula. We also calculated sample size for the second objective, and sample size almost 284. And our dependent variable was stage of diagnosis, which was dichotomized as early and late based on the clinical implication. And these are our independent variables. And the data management and analysis was done. We entered data with the P-info, and we use odds ratio with 95 confidence interval. P-value of 0.005 was used both for selection as well as multiple logistic regression. And we fit also the HL statistics to see whether our study, our model was fit or not. And we also secured ARV protocol. So in the result, the mean age of women at presentation was 53.2, and it ranges between 18 and 80 years. Most of the women coming from the rural area, more than half, like 54%, were married. Nearly 2/3 of the patients they didn't have medical insurance, and around 75% of the women were postmenopausal. So when we see the clinical characteristics of these women, all patients were presented with symptoms related to cervical cancer, with most common symptom being vaginal bleeding at 45.4%, vaginal discharge at 36%, and abdominal pain at 18%. And the median duration of the presenting compliance was 6 months. It ranges between 0.4 to 84 months. All study participants had visited at least 2 health facilities before their arrival to Babagon Specialized Hospital, and the majority, almost 90%, were seen in 3 or more health facilities. And approximately 9 in 10 of the study participants, the diagnosis was suspected on the referral, like 86%. The diagnosis of cervical cancer was suspected. And on clinical examination, the cervical mass was assessed for 99.6, almost all patients. The mean diameter was 4.2 plus or minus 7 centimeter. This assessment is based on the clinical estimation by the clinicians, and 2/3 of the participants had cervical mass size which is greater than 4 centimeter or 4 centimeter. And there was like 48% of patients, vagina was involved, and parameter involvement was reported in 37% of the study participants. And there was an ultrasound report of hydronephrosis in 51%. Histology showed squamous cell carcinoma in 92% of the patients, and when we see the stage, close to 70% of our patients were in late stage, stage 2B to 4, and early stage can contribute to 20.4% of the study participants. So we assess these variables in bivariate logistic analysis, and participant place of residence, parity, presenting complaint, history of the use of oral contraceptive pills, HIV serostatus, comorbidity, hemoglobin level in milligram per dl, and cervical mass size. These were the factors which were selected to be associated with the dependent variable. And when we fit the multiple logistic regression, so we did the backward type of multivariable logistic regression, and we get the rural residents, anemia, cervical mass, and HIV positive women were found to be at risk, at increased risk of being diagnosed at late stage. So these are the other variables we get. So in our study, the majority of the study participants were diagnosed with late stage cervical cancer. It's almost 75% came in late stage diagnosis, and this is concurrent with other studies globally as well as in Ethiopia. So these are the most important factors that we have identified: the place of residence, HIV serostatus, anemia, which is defined as hemoglobin level less than 12 gram per dl, and cervical mass size of greater than or equal to 4 centimeter. So when we see the place of residence, the odds of being diagnosed with late-stage cervical cancer was higher among rural dwellers, and more than 3/4, like 77% of patients with late-stage cervical cancer were from rural settings. This finding is in line with findings from the systematic review and analysis which was done by Wase et al. And this might be due to patients who live in rural area may have lack of information about the symptoms and signs of cervical cancer, as well as lack of access to cervical cancer screening, diagnosis, and treatment service. And this may be coupled with social, cultural, and economic barriers to cervical cancer. And the other factor was anemia, which was assessed with an odds ratio of 3.42. So anemia was found to be stronger predictor of late-stage diagnosis, and in the current study, 41% of women with late-stage cervical cancer had hemoglobin less than 12 gram per dl at the time of diagnosis, and 78.3% of women in this group were presented with vaginal bleeding. So this finding is supported by other findings in Addis, Tanzania, and the link between anemia and late-stage cervical cancer may be explained by the fact that patients with advanced stage cervical cancer, they may have vaginal bleeding for a prolonged period of time, and that can be coupled with an outcome of anemia, with a resultant decrease in hemoglobin concentration, while on the other side, anemia diagnosed by healthcare professionals may be attributed to other causes, and which may result in unforeseen delay in the diagnosis of cervical cancer, and patients may come with late stage at the end. So the other is cervical mass size of 4 centimeter or more, which was associated with an increased odds of being diagnosed with late stage cervical cancer. So this study is also supported by findings from Morocco, and where 81% of patients had tumor size greater than or equal to 4 centimeter, and it was associated with advanced stage, poor survival, and high recurrence risk. In the present study, we get HIV positive status, and patients with who are HIV positive found to be less likely to present with late stage. They present with early stage diagnosis. And when we go through the literatures, these women, due to the different programs they are enrolled, they are being recruited, they are they have the exposure to information. They are also linked to the community health workers, so they have the chance to get early screening. So because of that, those women who are HIV positive in this particular study were highly likely to present with early stage disease than late stage disease, and this underscores the importance of screening for all women in the eligible age category. So when you see the strengths and the limitation of the study, this study is the first study carried out to determine the stage of diagnosis of cervical cancer and explore associated factors with cervical cancer in tertiary care setting among symptomatic women in northwest Ethiopia. However, our finding should be interpreted in line with some of these limitations. Like first, this was a retrospective study and the population analysis in a single center, and it cannot be generalized. And the other is there was a lack of information about other important factors, including educational level, HPV infection status, and other clinical parameters. And third, the medical records were not recorded with research intention, which may cause many records with incomplete information. So future analysis with multi-center data with large sample size, more variables being added is needed. So in conclusion, the study indicated that the proportion of late-stage presentation among cervical cancer patients was high, and patients coming from rural, those with anemia, larger cervical mass are at increased risk of late-stage disease, while HIV positive serostatus lowers the odds of late presentation. So our recommendation is expand cervical cancer education for radiologists and cancer treatment center, and prioritize to patients with anemia, larger cervical mass in the areas are the most important areas of intervention, and the qualitative study should be incorporated in order to better understand the factors which will delay in seeking cervical cancer diagnosis and treatment. Thank you so much.
Thank you, Dr. Eyaya. We can take maybe just one or two questions, burning questions from the audience for two previous presenters, Ahmad and Dr. Eyaya. Anyone has a question, they can just raise up their hands. Is it that we are very tired, or everything that has been explained is well understood? Eh? Okay, go ahead.
Thank you. I would like to ask a few questions about the equipment. I would like to know the sensitivity about every screening test has to have the sensitivity and specificity. And the second question is the cost and maintenance. The third question is the approval by the WHO or other international organizations like FIGO or other FDA in the United States or other countries. Thank you. Those are
Okay, thanks. Thanks for your questions. Actually, it's very important. Usually, I put the sensitivity and specificity in the presentation, but I prefer to skip just to allow you to ask if you wish. Actually, the company started with some research in some countries. As we can see, they started in Vietnam, then it have expanded to China, then after that to some countries like Saudi Arabia and Middle East, some countries in Africa. So they usually each year introduce and print out annual report. This report includes the experience of each country. So the sensitivity, if you refer back to the annual report, you will find that it's above 88% in 2023. Now, in 2024, I came to know newly that it will be above 90%. The sensitivity, the accuracy of the system is above 20, is above 90%. And I came to know that there is some countries use the system with 98% accuracy, the sensitivity and the sensitivity, the specificity is more than 84%. It will not be less than 84%. So the sensitivity 90%, which means that we have false negative around 10%, which is very nice, very great regarding and referring and comparing with pap smear, which is around 65 or something like that. The specificity, we have 84% or above. Sometimes we have around 89 in some countries, which came from that, the fact if we increase the accuracy, we will have some false positive. This false positive will come from the acute and severe infection. If a patient has an acute or severe infection, the system will give it's positive, abnormal, okay? But usually, the system, if you start from the machine, from the laptop, it will ask you as a survey what you see inside the speculum. If you say, yeah, there is a discharge or some symptoms of the infection, the system will not make the exam. For that reason, next year, we will have the annual report of 2024 with accuracy 98% and specificity more than 88% in most of the countries. This is the first question. The second one is the price. The price, we have the machine itself, we have this device, which is portable, we have the charging base. The device price in Africa around 7,000 USD. It's not expensive. There is no lab equipment, it's just this device. And actually for the infection control, we have the sensor, the single-use sensor. This sensor will be used for each patient. It's the consumables, the only consumables we use for the device. It's around 20 to 22 USD for each patient. It's a little bit expensive if you compare with the brush of the pap smear, but actually, as we say, we have lights, we have electricity, we have micro voltage. So we need something to deliver this tiny voltage to the cervix, which is, if you see, there is some yellow blades inside, which is gold, not copper. So that it's a little bit expensive. But if you compare the whole procedure, if we have patients came to the clinic, we can do pap smear, something non-comfortable. In the result, we have to do HPV DNA. Positive, we have to go to colposcopy. After that, we may have normal or abnormal by colposcopy. Our device will start within 5 minutes. You will have the results without any need to go pap smear, HPV DNA, colposcopy. Even if the patient came and we test the cervix and we have abnormal result, you will go directly to colposcopy. No need to do pap smear or HPV DNA. Yes, the approval. Sir, this company depends on AI. So it has started commercial after 2020. As we all know, the pandemic of COVID-19 has postponed most of commercial. So it's just, let's say, 2 years old starting commercial seriously. It's approved by CE certificate in Europe. It's approved by Japanese FDA. It's approved by Chinese FDA. US FDA, this year, they have submitted their request to start some research in USA, and they have paid. You have to pay something like $1.5 million USD to support the research. Then after they get the result, they will be FDA approved. They have newly submitted their request. But for WHO said that you can use pap smear, you can use HPV DNA, or any high-performance equipment to test the cervix. So this considered as high-performance equipment. It depends on each country alone or separately. Let's say in Jordan, we have done many trials in Ministry of Health, in Royal Medical Services, in Jordan University Hospital. We have got the approval from Ministry of Health, and now they are studying and going to insert through screen side by side with pap smear, with HPV DNA, with colposcopy to detect the cervix cancer in MOH, in Ministry of Health, in Jordan guideline. Saudi Arabia the same, China the same, Vietnam the same. I think within 1 or 2 years, we will have the WHO approval.
Thank you so much for the two presenters. I have a question for, sorry, my name is Magnifique. I have a question for Prof. Ayaya and one for Ahmad. So, Prof, a nice presentation. My question is, you mentioned about oral contraceptive pills being one of the factors that contributed to the people showing up at the later stages. So, either you correct me if I did not get it well, because we know, yes, that OCPs could be one of the factors. However, did we quantify how long the people were on OCPs, and was that necessarily a factor, or it was just like coincidence? Because we know how much we are telling people to use oral contraceptive pills, so I wanted to let that come out truly if that could contribute to late stage of cervical cancer. So a question to Ahmad. Unfortunately, cervical cancer is still a disease of the poor. When we think about 7,000 USDs, that's pretty much a 2 years salary of a gynec or an obstetrician gynecologist in Rwanda. When we think about $20, that's, if we think about our country, that's like a family community health-based insurance for the family. So with that kind of tool, however much we have a great sensitivity and a very good specificity, it's not going to be overused in a country like ours where poverty is a problem. So I am definitely going to give you a challenge. How the private people with the minds and AI be able to produce a tool like this can think in terms of end users of us with the means that we have at hand. Thank you.
Okay, thank you for your question. And in the analysis, oral contraceptive pill was not associated with stage at diagnosis. It was initially associated in the bivariate analysis. When we fit multivariable logistic regression, it was out. So the 4 factors are HIV, anemia, cervical mass greater than 4 centimeters, and the place of residence. These are the associated factors. Thank you.
Yeah, thank you, sir, for your question. Your question about the price and the challenge of the price. And actually, this is the most challenging point ever we face in each country. I will give you just an example. We have installed a system, one device in Palestine. It was sold around 20K USD, not 7, okay, because they consider Palestine and Jordan as middle income country, not low. I'm not the why. So we have installed one. They use this device to screen most of women. It's an oncology center, okay? The first step they have done that to convince the insurance companies to cover the test cost. Any device, any technology comes new to us, just like iPhone, just like Samsung, Android telephones. It will come with $1,000 USD dollar price. But after 1 year, it will be cheaper. But I believe this technology will not come too much cheaper because we have some challenging in manufacturing. I said it's gold. We usually don't say this information because some clients will say, it's gold. So, but it's gold. So it will not become cheaper, I believe, because you see, globally, the gold is going up. The price is increasing. It's crazy. So the price will not be challenged when it will be considered as guideline. Trust me, in Jordan, we are now going to install many systems. Sometimes we can install the system with very low price because you are buying the consumables with a huge number. So it depends on the country, it depends on the commercial situation of the country and how much the country will use the device. TrueScreen company is very supportive, trust me, and this will not be a problem. Promise. Thank you, sir.
Thank you to our presenters and panelists. I think we have come to the end of this session. Thank you for your attention. Thank you for being part of this. I would like to pass the microphone to our MC. I thank you so much. You can also give me a hand clap as well. I think I deserve it.
Definitely a well-deserved hand of applause. It was a great day. What did you think?
I thought it was great.
Yeah, it was our first scientific, and I think it was great. Thank you so much for joining. We just got some few housekeeping announcements to make before we head out and have a well-deserved coffee break and connecting time. So first of all, we'd like to remind the speakers of tomorrow to make sure that their presentations are well aligned with our IT team and make sure there's no problem, no issues, just to make sure that tomorrow goes smoothly as we prepared. Second,
if everyone can come on time, we would love to start early. And yeah, just have a good run through of the day. So registration is at 8 to 8:30 and we'll be starting promptly at 8:30. Thank you.
And last but not least, please remember to inform the world what we are learning here. Don't keep it with yourselves. Tomorrow is going to be yet another great day and with good panelists. Make it on time as we said. And that is it from us. Please head out, get to the booth and exhibition people. They have amazing things that they want to show us. Get there so that they can talk to us. And remember to grab coffee and a juice and a snack as we go home. And talk to your neighbors and exchange contacts. Thank you. Hand of applause to the MC.
Welcome to Mega Life Sciences, established in 1980 and a public company since 2013. With a global presence in over 33 developing countries, and GMP approvals in over 50, Mega is a leader in the health industry. Mega Life Sciences has proudly served the people of Rwanda for over 9 years, supporting health and wellness in the region. Our manufacturing plants span across the globe, ensuring the highest quality products for all. At Mega, we believe in helping people stay healthy as long as they live. We are passionate about women's health and focus on developing brands with the modern woman in mind. During pregnancy, nutrition is key, but diet alone may not be enough. That's where Mega Prenatal comes in. Small, easy-to-swallow capsules packed with essential micronutrients for a healthy pregnancy. Ferritone offers a breakthrough liquid in a capsule formulation, eliminating metallic taste and GI irritation for easy, assured iron absorption. Calcivita's small, vanilla-flavored capsules ensure optimal calcium absorption without digestive discomfort. For fast relief from pain, Gofen's unique clear cap technology delivers results in just 15 minutes with minimal GI irritation. Mega's portfolio includes a NAT 400, the purest form of natural vitamin E, Zeman for enhanced testosterone support, and a NAT cream for flawless skin with reduced stretch marks. With a wide range of innovative products, Mega Life Sciences is committed to your health and wellness, wherever you are.
Mega, we care.